So, with all your permissions, I'm starting the session for today. So, good afternoon and a warm welcome to all the dignitaries present here. I am Nang Himahi from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet serves as the digital partner for this event hosted by the Indian Association of Clinical Cardiologists, Gujarat. The focus of today's session is the ECG webinar for family physicians. So let's begin today's session, for which I would like to invite Dr. V K Jagnany sir to take over. Kindly proceed with your talk, sir. Over to you.
Thank you. Thank you so much. Uh, Today's session is planned by FFPI and the Ranchi branch is planning this particular CME, Zonal conference. So this is how we are planning it. Uh, सबसे पहले I would like to invite Dr. Pragnesh Shah, President FFPAI, to have his kind words.
Thank you, Dr. Jagnany. First of all, I welcome all of you on the behalf of Federation of Family Physicians Association of India. Uh, since last 1.5 years, we are promoting scientific activity on physical or on the webinar mode very frequently, and for that, I really congratulate Dr. Sanjay Shah and Dr. Preeti for their hard, really dedicated efforts for this ECG webinar, FPECGCON. I really congratulate Dr. Vinit Jagnany to have a very hard work to organize this ECG Con 2024 at the national level. Uh, I again thanks team FPA Rachi for all the support, and thanks to the, ClearNet for all the technical supports. So I request to start the session. Thank you.
Before I start the session, I also request Dr. Sanjay Shah, sir, senior person in the association, to have 2 words from him.
Yes. First of all, I congratulate Dr. Jagnany to arrange such a good CME on ECG. As you all know, nowadays ECG is very essential investigation in our family practice. And today we will be very lucky to have very good speakers. We will definitely learn so many good new things on ECG. So with me today, I am starting our first session. I, Dr. Sanjay Shah, with Dr. Rakesh Khanna from Ranchi, then Dr. Kapil Khanna from Delhi, and Dr. K.K. Tiwari from Bilaspur. We are chairing the first session, and the first session will be by Dr. Sunil Yadav. Dr. Sunil Yadav is he has done his diploma in cardiology, and he's from Jumri Talai. And I welcome Dr. Sunil Yadav to say on normal ECG. Welcome, sir.
Thank you so much. Before we begin the session, let's have a prayer. Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kurume Deva Sarv Karyeshu Sarvada. Praying Lord Ganesh and Lord and Ma Saraswati. Ya Kunnendu Tusharahar Dhavla Ya Shubhra Vastravrita Ya Veena Vardand Mandit Kara Ya Shwet Padmasana. या ब्रह्माच्युत शंकर प्रभृति भिर देवै सदा वंदिता सा मांग पातु सरस्वती भगवती निशेष जाड्यापहा. As rightly said, first session we will have Dr. Sunil Yadav, clinical cardiologist from Jumri Talaya, and chairing the session Sanjay Shah sir, who is senior physician from Ahmedabad with special interest in pediatrics, diabetes, lifestyle disorders, respiratory diseases, and psychiatry. He is also past president of Maninagar Medical Association and Ahmedabad FPA, and presently joint secretary of FFPI. We also have Dr. Rakesh Kumar, Kapil Khanna, and Dr. K.K. Tiwari, who are clinical cardiologists. With this, I hand over the session to Dr. Sunil Yadav for his presentation on normal ECG. Dr. Sunil Yadav. Yeah. Kindly unmute yourself and share your slide. Technical team can help him.
So slide कैसे it is my first, it is the first time I am attending this kind of webinar on Zoom. So please help and guide me how to share slide.
So there's one option in green color. It's share screen. So kindly click on, yeah.
Yeah.
Have you found it, sir?
Yeah.
Leader.
Yeah, sir. Kindly click on that in the share screen button and click on the PPT that you are going to share, sir.
Take it 20 minutes. Within 20 minutes. I should keep myself restricted only to acute coronary syndrome, which includes stool and venous. The pathology of these three entities are same, only the difference is in the degree of their damage. In the degree of their damage. In non-swollen angina and in non-STEMI, there is partial occlusion of the coronary artery. There is partial occlusion of the coronary artery involved. There is partial occlusion of the coronary artery involved, resulting in the necrosis of the most vulnerable part of the myocardium, which is the subendocardial myocardium, which is prone to maximum stress, resulting in maximum oxygen requirement.
Please mute or everybody except speaker. Everybody has to mute themselves.
Therefore, subendocardial express. But there is total occlusion of the coronary artery.
If Dr. Sunil is not able to share his screen, please clinical team assist clinical team.
Hello, sir. Dr. Sunil, sir.
हाँ मैं सुन रहा हूँ मैम, बट उसको मैं कर नहीं पा रहा हूँ। जगनानी बोस से मैं शेयर किया था ये बात को, लेकिन हम
नीचे देखिए सर, आपको एक ग्रीन कलर का ऑप्शन होगा, वहां पे शेयर स्क्रीन लिखा होगा सर, आपको उधर पहले क्लिक।
शेयर मैं देख रहा हूँ बट फाइल नहीं खोज पा रहा हूँ। कहाँ वो मेरा व्हाट्सएप में?
अच्छा सर, आप आपका डाउनलोड्स में जाइए सर।
डाउनलोड्स का मैडम ऑप्शन नहीं आ रहा है इसमें मेरा।
सर आप
मेरा व्हाइट बोर्ड आ रहा है, स्क्रीन आ रहा है, वेब यूआरएल
नहीं तो डॉक्टर Sunil, kindly share your slides. She will run the slides for you.
डॉक्टर सुनील सर,
हाँ
आप
मैंने
लैपटॉप
स्लाइड आपको व्हाट्सएप की है शालिनी जी को।
उनको व्हाट्सएप कर देना।
Shalini, I WhatsApp you the slide.
Yes, I am sharing with Himaki. Also, I've shared Himaki's number and email ID in the group. So in case you need to share any slide, you can do it with her, because that way it will be easier for her to directly get the access. Himaki, did you receive it? I just shared.
Yeah, just give me a moment. I'm checking.
Yeah, okay.
Shalini, kindly share the PPT on my email ID, please.
Okay.
Till the PPT display, Dr. Sunil Yadav, you can say something on normal ECG. You can start.
Without slide.
Just now, just introduction.
Achha. So, good. Myself, Dr. Sunil Kumar Yadav, MBBS, PG, TCC from Apollo Hospital, Ranchi. First, good afternoon, everyone, and thanks to the organizing committee for giving me the opportunity to say a few words on normal ECG. So everyone knows better than me about ECG. That normal ECG, it is very, one should have, so normal ECG is the electrical representation of the activity, graphical representation of the electrical activity occurring in the heart. It is represented.
Hello, Dr. Sunil, sir.
Yes, sir.
Sir, sorry to interrupt you in between, sir. So I'm sharing my screen, sir. Kindly let me know if it's visible to you or not.
Yeah. Please share.
So is my screen visible to you?
Yes.
Okay.
Yes.
So, sir, kindly guide me accordingly when to move to the next slide, sir.
Yes, sir. Next. Yeah. This is the ECG machine with the patient. Next slide. So introduction. The ECG is one of the simplest and the oldest investigation available. Yet it can provide a wealth of useful information and remains an essential part of the assessment of cardiac patient. With modern machine surface, ECGs are quick and easy to obtain at the bedside and are based on relatively simple electrophysiological concepts. Next slide, please. An ECG is simply a representation of the electrical activity in the cardiac muscle as it changes with time, usually printed in a paper or graph. Like other muscle, cardiac muscle contracts in response to electrical depolarization of the muscle cells. It is the sum of this electrical activity was amplified and recorded for just a next slide. Yeah, this is the pattern of normal ECG and showing anatomy of the heart. PQRST wave in a normal, showing normal pattern of the ECG, basic ECG. Next slide. So electrophysiology of the heart. The normal cardiac cycle begins with a spontaneous depolarization of the sinus node, an area of a specialized tissue situated in the high right atrium. A wave of electrical depolarization then spreads through the RA and across the interarterial septum into the left atrium. Next slide. And then artery are separated from the ventricles by an electrically inert muscle ring, so that in the normal heart the only route of transmission of electric depolarization from atria to ventricle is through the AV node. The AV node delays the electrical signal for a short time, and then the wave of depolarization spreads down the interventricular septum by the bundle of Hitch, and the right and the left branches into the right ventricle and the left ventricle. Next slide. Hence, with normal conduction, the two ventricles contract simultaneously. And important in maximizing cardiac efficiency. After complete depolarization of the heart, the myocardium must then repolarize before it can be ready to depolarize again for the next cardiac cycle. Next slide. voltage and timing interval. It is conventional to record the ECG using a standard measures for amplitude of the electrical signal and for the speed at which the paper moves during the recording. This allows first the ECG appreciation of heart rates and cardiac intervals, and meaningful comparison to be made between ECGs recorded on different occasions or by different ECG machines. Next slide. The amplitude or voltage of the recorded electrical signal is expressed on an ECG in the vertical dimension and is measured in millivolts. On the standard ECG paper, 1 millivolt is represented by a deflection of 10 millimeter. An increase in the amount of muscle mass, such as with the left ventricular hypertrophy, usually results in a larger electrical depolarization signal and so a larger amplitude of the vertical deflection on the ECG. Next slide. So you can see a sample of a standard ECG paper showing the scale of voltage measured on the vertical axis and against time on the horizontal axis. Each small square represents 40 milliseconds of time, and 1 millivolt equal to 10 mm. That is on vertical line. Next slide. Voltage and time. An essential feature of the ECG is that the electrical activity of the heart is varied with time. In other words, plotting electrical activity on the vertical axis against time interval in the horizontal axis. A standard ECG paper moves at 25 millimeter per second during real time recording. This means that when looking at the printed ECG, a distance of 25 millimeter along the horizontal axis represents 1 second in time. Next slide. Next slide. The normal ECG. Next slide. Yeah. Normal ECG starts with first the P wave. The first structure to be depolarized during normal sinus rhythm is right atrium, closely followed by the left atrium. So the first electrical signal on a normal ECG originates from the atria is known as the P wave. Although there is usually only one P wave in most leads of an ECG, the P wave is in fact the sum of electrical signals from the two atria, which are usually superimposed. Next slide. There is then a short physiological delay as the AV node slows the electrical depolarization before it proceeds to the ventricles. This delay is responsible for the PR interval. A short period where no electrical activity is shown in the ECG, represented by a straight horizontal or isoelectric line. Next slide. This is the normal ECG graph. You can see the PR interval, PR segment, QRS interval, QRS complex, ST segment, and ST interval, and U wave. Next slide. The QRS complex. The depolarization of the ventricles result in usually the largest part of the signal because of the greater muscle mass in the ventricles, and this is the key of the QRS complex. The Q wave is the first initial downward or negative deflection. The R wave is then the next upward deflection, provided it crosses the isoelectric line and becomes positive. The S wave is then the next deflection downwards, provided it crosses the isoelectric line to become briefly negative before returning to the baseline. Next slide. Next slide. In the case of the ventricle, there is also an electrical signal of repolarization of the myocardium. This is shown as the ST segment and the T wave. The ST segment is normally isoelectric, and the T wave in most leads is an upright deflection of variable amplitude and duration. Next slide. This is the diagram of the ECG with the anatomy of the heart. So SA node is situated in the right atrium. Conduction travels from right atrium to the AV node, then bundle of is to the left bundle branch, and then the right bundle branch. So accordingly, graph representing the different conduction system of the heart or area of the heart. Next slide. So normal interval. The recording of an ECG on a standard paper allows the time taken for various phases of electrical depolarization to be measured, usually in milliseconds. There is a recognized normal range of such intervals. So PR interval measured from the beginning of the P wave to the first deflection of the QRS complex. Normal range is 120 to 200 milliseconds. That is 3 to 5 small squares on ECG paper. Next. QRS duration. Measured from the first deflection of the QRS complex to end of the QRS complex to the isoelectric line. Normal range up to 120 milliseconds. That is 3 small squares on ECG paper. Next, QT interval. Measured from first deflection of QRS complex to end of the T wave at isoelectric line. Normal range up to 440 milliseconds. Though varies with heart rate and may be slightly longer in females. Next, heart rate estimation from the ECG. So standard ECG paper allows an approximate estimation of the heart rate. Each second of time is represented by 250 mm, that is 5 large squares on our horizontal axis. So if the number of large squares between each square complex is 5, the heart rate is 60, 3, the heart rate is 100 per minute. So the formula RR interval divided by 5. Next, two ECG electrodes, important thing. Two arrangements, bipolar and unipolar leads, bipolar leads. One in which the electrical activity at one electrode is compared with that of the another. By convention, a positive electrode is one in which the ECG records a positive deflection, that is upward deflection, when the electrical impulse flows towards it, and a negative or downward deflection when it flows away from it. Next, unipolar lead, one in which the electrical potential at an exploring electrode is compared to a reference point that averages electrical activity rather than to that of another electrode. The single electrode termed the exploring electrode is the positive electrode. Next, limb leads 1, 2, 3, AVR, AVL, and AVR explore the electrical activity of the heart in the frontal plane. That is the orientation of the heart seen when looking directly at the anterior chest. And the standard limb leads 1, 2, 3 bipolar leads form a set of axes of 60 degree apart. Lead 1 composed of negative electrode on the right arm and positive electrode on the left arm. Lead 2 composed of negative electrode on the right arm and positive electrode on the left leg. Lead 3 composed of negative electrode in the left arm and positive electrode on the left leg. Next, augmented voltage leads AVR, AVL, AVF unipolar form a set of axes 60 degree apart but are rotated 30 degree from the axis of the standard limb leads. AVR exploring the electrode located at the right shoulder, AVR exploring electrode located at the left shoulder, AVR exploring electrode located at the left. Next, reference point for the chest leads. The point obtained by connecting the left arm, right arm, and left leg together. B1 position at the fourth intercostal space just to the right of the sternum. B2 position in the fourth intercostal space just to the left of the sternum. B3 position halfway between the B2 and B4. B4 position at the fifth intercostal space in the mid clavicular line. B5 position in the anterior axillary line at the same level as B4. B6 position in the mid axillary line same level as before. Next, V1 and V2 monitor electrical activity of the heart from the anterior septum and right ventricle. V3 and V4 monitor electrical activity of the heart from the anterior aspect. And V4, V6 monitor electrical activity of the heart from left ventricle and lateral aspect. Next, axis deviation. Interpretation of the ECG relies on the idea that different leads in the ECG leads 1, 2, 3, AVR, and the chest lead view the heart from different angles. This has two benefits. First, leads which are showing problems, for example, ST segment elevation, depression, can be used to infer which region of the heart is affected. Second, the overall direction of travel of the wave of depolarization can also be inferred, which can reveal other problems. This is termed the conduction lead. Next, so axis deviation. Left axis deviation when is called when it is minus 30 to minus 90 degree. Normal may indicate left LHV, left anterior fascicular block or Q waves from the inferior wave. Normal variant level may be considered normal in case of pregnant women and those with emphysema. Right axis deviation plus 90 to plus 180 degree may indicate left posterior fascicular block Q waves from high lateral MI or a right ventricular strain pattern. Normal variants may right axis right deviation is considered normal in children and is considered a standard effect of the dextrocardia. Extreme right axis deviation it is next. Next. Thank you. Thank you very much,
Doctor. Thank you very much, Dr. Sunil Bhai.
Yes, sir.
Now, is there any questions? As this is a normal introduction of normal ECG, we will see different kind of abnormalities in ECG by different speakers. But if you have any questions regarding normal ECG, one can ask. Though the presentation of Dr. Sunil Yadav was good, but nowadays there are very good presentation by different speakers. One of the speaker is Dr. Waqas Fazal. If anyone wants to see Dr. Waqas Fazal's YouTube video, they are excellently giving about ECG and different medical conditions. I request all of you to see the videos, YouTube videos of Dr. Waqas Fazal. I have gone through the ECG also by Dr. Waqas Fazal, and he was excellent in his talk. Now for today, is there any question for Dr. Sunil or we can go ahead?
If we do not have any question,
ClearNet team, do you have any question in ClearNet live viewers?
No, sir, not yet.
Okay. So I am thankful with my whole chairperson's team to Dr. Jagnany for giving us as a chairperson for this session. And now I request for the second session, Dr. Jagnany.
Yes, sir. Thank you so much. Thank you so much, Dr. Sunil, for your presentation, and Sanjay sir for the chairing the session. Kindly accept the certificate online here. Dr. Sanjay sir, Dr. Rakesh Kumar, Dr. Kapil Khanna, and Dr. K.K. Tiwari. Here I have a small thing to say. Somehow the second speaker, Dr. Manoj Garela, is not available due to sudden family emergency. So I request our third speaker, Dr. Pritam Partha Day, to kindly take over from this point, and I request the chairpersons of the second session to remain here, Dr. Anuradha Paramesh Madam, Dr. Amar, Dr. Manav Vadhera, and Dr. Chitrali Singh to kindly be here. We will have to miss this session because Dr. Manoj Garela could not attend because of some urgent family thing which has come up. So for the next session, I request Dr. Partha Day will be presenting on ECG in CAD. For that, we will chairing Dr. Deepak Khetan sir, who is fellow of IAMS and ICP and CCMD. He is senior consultant based at Ahmedabad, president of CCDSI, Dean ICCMD and CCDSI. He is a wonderful speaker. He has received Master Teacher Award as well as Living Legend Award and is supposed to be Pride of India Award. He has written more than 100 articles and 15 e-books. I also welcome Dr. Deenbandhu Sahu from Bhavani Patna, Dr. Rajni Chaudhary from Dhanbad, and Dr. Umesh Kashyap from Palampur. Of course, Dr. Anuradha Paramesh to be here. So I kindly request Dr. D.P. Khetan sir to introduce Dr. Partha Day.
Thanks, sir. It's my pleasure to introduce Dr. Partha Sen. He's a very famous clinical cardiologist from Kolkata, and he's a known well personality in the field of cardiology. He's having all the facilities of cardiology to his hands, including the lab facilities. In nutshell, I would like to, instead of the detailing all the things, I would like to invite Dr. Partha Sen, Partha Day, as a speaker on these occasions, because after that I would like to give my comments. Dr. Partha Day, please.
Dr. Partha, unmute yourself. Dr. Partha, unmute. Dr. Partha, please unmute yourself.
Yes.
Okay.
Yes. Am I now audible?
Yeah.
Yes, audible, sir. Audible, sir.
Can you please show my slides? What I had already shared to Shalini? Yeah.
So is
Okay,
my
all
screen
right.
visible to you?
Yes, perfectly visible. So, I am Dr. P.P. Dey from Calcutta. I am at present attached to the cardiology department of Narayana Multi-Specialty Hospital, which is a branch of Arrhythmia International Institute of Cardiac Sciences of Calcutta. So I would like to thank Dr. Jagnany, Dr. Pragnesh, Dr. Chaki for giving me this opportunity to discuss about the ECG changes in coronary artery disease in front of this esteemed audience. Now, in this limited 20 minutes time, I shall keep myself restricted only to acute coronary syndrome, which includes unstable angina, NSTEMI, and STEMI. Next slide, please. Now, the pathology of these three entities are same, only the difference is in the degree of damage. In unstable angina and NSTEMI, there is partial occlusion of the coronary artery involved, resulting in the necrosis of the most vulnerable part of the myocardium, which is the subendocardial myocardium, which is prone to maximum stress and resulting in maximum oxygen requirement. Therefore, here only the subendocardial injury takes place. But when there is total occlusion of a coronary artery, there is necrosis of whole of the myocardial thickness. That is, there is transmural necrosis, which also involves the epicardium. This is why the ECGs of NSTEMI and STEMI differs. In NSTEMI, as the direction of the vector is towards the necrotic tissue of the subendocardium, as shown in this picture, here these vectors are directed away from the leads facing this area. And this produces a negative ST segment, that is ST depression. Whereas in transmural MI of STEMI, the vector is directed towards the epicardium and the leads facing towards this area, resulting in ST elevation in ECG. Now, this is the basic pathology and formation of ECG changes. Now, what is the timeline of ECG changes in STEMI? We all know that the earliest change in STEMI ECG is the hyperacute tall T wave. Next, there is appearance of ST elevation, then pathological Q wave, and in fully evolved phase, there is pathological Q along with ST elevation and coving, and there is T wave inversion. And ultimately, after some time, few hours or days, the ST comes towards the baseline, remaining the pathological Q wave and T wave inverted. And in subtotal occlusion, in STEMI, and in some cases of unstable angina, there is ST depression along with deep T wave inversion in leads facing the ischemia, and the typical T wave inversion is called valence T with a broad base. Now, here in the next slide, please. Next, please. These are all told. Next, please. Next slide, please. Next slide. Now, here you see the changes of ST elevation. That means J point is elevated. You follow the picture in B. First picture is the normal ECG where the ST touches the baseline. Then there is slight elevation of the J point and ST, then gradual elevation of ST. Ultimately, the ST is elevated, and the ST along with the T wave takes the whole descending limb of the R wave, producing a giant R wave. And lastly, there is the fully evolved phase, as I told you, pathological Q with ST elevation and coving pattern with Q wave inversion. So here you see the typical ST elevation pattern is either it is sloped upwards, or it is horizontal, or it is a convex type of coving. Now, here you see the picture of an anterior picture of an anterolateral valve STEMI. Here in early stage there is ST elevation. Next slide, please. Next slide. Next, please. Here you see the picture of an anterolateral valve STEMI. Here in early stage, there is ST elevation in lead 1 AVL and V1, V2, V3, V5, V6. And in the evolving phase, you see in the same leads, there is pathological Q wave formation with Q wave inversion along with the ST coving or ST coming towards the baseline. And below this, there is STEMI of inferior valve STEMI. Here you see that there is ST elevation in lead 2, 3 AVF in the early stage, and in the evolving phase, in the same leads, there is formation of pathological Q and T is inverted. And in these two ECGs, you will note some ST depression. ST depression is seen in the opposite leads. This is called reciprocal ST depression. You see in the anterolateral valve STEMI, there is ST depression seen in lead 3 and AVF, whereas in inferior valve MI, you see that there is ST depression in lead 1 and AVL. And these reciprocal changes are very important to note because these may indicate the proximal artery obstruction in some cases. Now, next slide, please. Now, what is the evidence of reperfusion? Now, when you get a case of ST elevation MI, our target is to reperfuse the patient either by thrombolytic agents or by primary angioplasty if we have that facility. Now, what is the evidence of reperfusion? The evidence of reperfusion is ST resolution. That means the percentage of reduction of ST elevation. And if the ST resolution by 50% or more is seen, it is a marker of successful reperfusion. If the ST resolution is more than 70%, it indicates a very good resolution. But if the resolution is absent or less than 30%, it indicates an absence of reperfusion. And one more interesting thing, if we start reperfusion early, when there is only ST elevation and upright T, and immediately after reperfusion, if we see the changes of fully evolved phase, that is development of pathological Q with ST coving and Q wave inversion, this is a better sign of reperfusion. Now, what is the definition of ST elevation? We all know that ST elevation means the elevation of ST of 1 millimeter in two contiguous leads, except a few, particularly in lead V2 and V3, where in some normal cases we may see ST elevation. But if the ST elevation is more than 2 millimeter in V2 and V3 only, in case of male more than 42 years, this is an indicator of ST elevation MI. But if the age of that male patient is less than 40, 2.5 millimeter ST elevation is required to consider it a case of STEMI. And in case of female, in case of V2, V3, if it shows ST elevation, that should be at least 1.5 millimeter, not 1 millimeter. And one more exception is lead V4R. We know that the importance of, oh sorry, next slide please, next slide. Yes, I am describing according to this slide. Now, in case of V4R, we know that V4R is important when we get an ECG of inferior wall MI. And in that case, we like to see whether the right ventricle is involved along with the involvement of the right coronary artery, because the management differs. Now, what is the ECG picture then? We get ST elevation in right-sided V3 and right-sided V4. It is called V3R and V4R. So, if we get ST elevation in lead 2-3 AVF along with ST elevation in V3R, V4R, and sometimes in V1, it is an indicator of proximal right coronary artery involvement, which is responsible for right ventricular wall MI, because the right ventricular branch is a branch of the right coronary artery. Now, what happens there? If the age of the person is more than 30 years, then only 0.5 millimeter ST elevation in V4R is sufficient to stamp it a case of ST elevation and the probability of RV infarct. But if the age of that male person is less than 30, then 1 millimeter ST elevation is required in V4R. And something to consider more is that ST segment elevation in inferior wall leads may be occasionally found in normal hearts, particularly in young females. We often come across with this. And ST depression in precordial leads should be always considered abnormal, and we should investigate thoroughly. Now, is it possible to localize the culprit artery after the ECG changes of ST elevation MI? Yes, it is possible. We all know that in the obstruction of left anterior descending artery, there is ST elevation from V1 to V5 all through. Now, where is the lesion? Is it in the proximal left anterior descending artery or mid or distal? If it is proximal left anterior descending artery, that means if it is proximal to the first septal branch. Oh, sorry, next slide please. I'm forgetting to tell you to show me the slide. Now, if the obstruction of the left anterior descending artery is proximal to the first septal branch, what happens then? In that case, ST elevation in V1 is usually 2.5 millimeter or more, and there is ST elevation of AVR also. Along with lead V1 to V5, there is ST elevation in AVR, and in many cases, there is associated right bundle branch block. As in septal MI, the right bundle is involved first. What happens if there is obstruction of the left anterior descending artery above the first diagonal branch? In addition to ST elevation in V1 to V5, there is ST elevation in lead 1 and AVL, as diagonal supplies the lateral wall. So here we will get ST elevation in V1 to V5, lead 1 and AVL. And in these two above a variety of proximal LAD obstruction, there is always ST depression in the reciprocal wall leads. That means leads of the inferior wall. That is, there is reciprocal ST depression in lead 3 and AVA. Now, what is the diagnosis? If we see that ST elevation is widespread, it is seen both in anterior wall leads as well as in inferior wall leads. That means ST elevation in V1, V2, V3, V4, V5 as well as lead 2, 3 AVF. Is it simultaneous obstruction of the left anterior descending artery and the right coronary artery? Is it a very serious condition? On many occasions, no. It is only obstruction of the distal part of the left anterior descending artery, which is a wraparound artery and wraps the apex of the left ventricle, supplying the inferior surface of the left ventricle. Now, what happens in case of inferior wall STEMI, where there is elevation of lead 2, 3 AVF? Is it due to right coronary artery obstruction in case of dominant right coronary artery, or is it a case of left circumflex artery obstruction when the left circumflex artery is a dominant one? We know that the posterior descending artery determines which one is the dominant. If posterior descending artery arises from the right coronary artery, the right coronary artery is the dominant. If PD arises from the SARC, then left part is the dominant. Now, how could you diagnose that whether LCX is blocked or RCA is blocked? If in lead 2 and lead 3, if we see that ST elevation in lead 3 is more than ST elevation in lead 2, it is usually an obstruction of the right coronary artery. Whereas if the ST elevation in lead 2 is more than the ST elevation in lead 3, it is usually an obstruction of the left circumflex. Along with that, in left circumflex artery occlusion, there may be elevation of lead 1 and AVL along with lead 2, 3 AVF, as the left circumflex, its OM branches supply the lateral wall of the left ventricle. And in case of right coronary artery obstruction, if it is the proximal part of the right coronary artery is involved, that means the branch above the right ventricular branch, that is the acute marginal branch, is involved, then there is ST elevation in V1 and V3R and V4R is present, indicating that there is RVMI as well, which is absent in right coronary artery obstruction distal to the right ventricular branch. In addition to this, in proximal right coronary artery occlusion, there we may get some avinodal occlusion. We may get some high degree AV block, that is second or third degree AV block, as that branch in 85% cases arises from the right coronary artery. Now, what is about the neglected lead AVR? If there is ST elevation of AVR only, and no other lead shows ST elevation, rather all other leads showing ST depression, what is that? Is it a minor thing or a major thing? Yes, it is a very major thing. It may indicate left main coronary artery occlusion or severe triple vessel disease. We should take up the case very seriously. Next slide, please. Here you see the picture of left anterior descending artery involving the D1, that is the proximal left anterior descending artery above the first diagonal branch on the left side. Here you see that there is ST elevation in lead 1 and AVL, along with ST elevation in V2, V3, V4, V5, V6. So this is proximal to D1, along with ST depression in the reciprocal leads, lead 3 AVF. You see that the lead 3 AVF is showing ST depression. Now on the right side is the proximal LED occlusion above the first septal branch. What you see here? Here you see ST elevation in V1 is more than 2.5 millimeter, and there is ST elevation in AVR also. And in some cases, there may be RVB as well, though it is absent here. Next slide, please. Here you see the picture of right coronary artery. Here you see that ST elevation in lead 3 is much more than the ST elevation in lead 2. It indicates right coronary artery occlusion in case of inferior wall MI. And on my right side, you see that it is an inferior wall MI due to left circumflex artery occlusion. Here you see that lead 2-3 AVF are showing ST elevation, but here ST elevation in lead 2 is more than the ST elevation in lead 3. Unlike the right coronary artery occlusion, where ST elevation in lead 3 is much more than ST elevation in lead 2. Next slide, please. Here you see that V4R and V3R is shown in case of an inferior wall MI. Here you see along with lead 2-3 AVF, which shows ST elevation, there is ST elevation in V3R and V4R, indicating a right ventricular wall infarction. That means obstruction in the proximal right coronary artery. And clinically, they give low BP, hypotension, and we should manage with IV fluids and other things you all know. Next slide, please. Now here you see ST elevation in both anterior and inferior wall leads. What I had discussed earlier, this may be due to a distal LAD occlusion. Here you see on the right side, the CAG is showing a wrap around left anterior descending artery, wrapping around the apex, supplying the inferior wall, and the distal part of it was occluded. And after a successful primary PTCA, the blood supply is recovered, and the artery is clearly seen that it is a wraparound artery, and it was the reason of this widespread ST elevation. Frequently, we may think that it is simultaneously an obstruction of the LAD and RCA, but not that. Next slide, please. This is an ST depression and tube inversion of NSTEMI. Next, please. Okay, this is important. Here it is shown how can we differentiate a case of normal LVB and an LVB with acute anterior wall MI. We know that in the setting of acute coronary syndrome, if the feature is typical of acute coronary syndrome, cardiac enzyme is high, and the ECG is showing an LVB which was absent in his previous ECG. If the previous ECG is available, and if it is absent in his previous ECG, the freshly developed LVB is an indicator of acute anterior wall MI. We need not see Garbosa criteria in those cases. But if his previous ECG shows pre-existing LVB, then we need to differentiate it from LVB with existing MI by Garbosa criteria. Now, what is Garbosa criteria? There are 3 points we should consider. There are 3 things we should consider. We know that in normal LVB, what is seen in ECG? In V1 and V2, along with the QS pattern or small RS pattern, there is ST elevation. And in V5, V6, along with the upright or notched R, there is ST depression. What happens here? In V5, V6, instead of ST depression, if you see that there is ST elevation of 1 millimeter or more, it is the highest predictive value. It indicates MI in LVB. Whereas in case of V1, V2, where ST should be elevated, if you see that here ST is depressed instead of elevation, then it is a case of STEMI. And third criteria is, if ST elevation in V1, V2, which is normally seen in LVB, if it is more than 5 millimeter, that also may indicate STEMI, because in normal LVB, ST elevation in V1, V2 is usually less than 5 millimeter, not crosses the 5 millimeter barrier. Next slide, please. What are other signs of detecting STEMI in LVB? This is Cabrera. What is Cabrera? Now, it is a shelf-like notch commonly seen in V3, V4. Here you see in this picture, there is a notch in the ascending limb of the S wave in V3 and V4. And this notch, and the duration of this notch should be more than 1 small square. That is more than 0.04 second. So this indicates an MI in the background of LVB if present. Next slide, please. Next, please. Now, how do you diagnose MI in presence of permanent pacing? Because we know that the RV pacing shows the ECG like LVB. So here also the Garbosa criteria is applicable, as I had discussed now. The same Garbosa criteria can detect whether there is a development of MI in a patient of pacing. But for old MI, where there is no ST elevation, for an old MI in presence of RV pacing may be challenging. But Puchiadakis has given a number of features which may be useful. One is Cabrera sign, as I had described now. Second is Chapman. What is Chapman? Chapman is a notch on upstroke of the R wave on lead 1, AVL and V6. Next slide, please. What is pathological Q wave, which is formed in case of STEMI and very little case of NSTEMI. Now, what is pathological Q wave? It is a Q wave with duration of more than 1 small square. That is more than 0.04 second or 40 millisecond. This is important. And the depth of the Q wave should be more than 25% of the height of the corresponding R wave. However, all pathological Q waves may not be pathological, and all Q waves do not represent an infarct. Now, how can we differentiate a non-pathological Q wave from a pathological Q wave during an ECG? If we get a pathological Q wave during our ECG procedure, then we may do a test. We may ask the patient to take a deep inspiration and hold and take an ECG. If that Q wave disappears, or if the amplitude of the Q wave, that means the depth of the Q wave reduces remarkably, that is probably a non-pathological Q. Q waves are present in inferior wall leads in more than 50% of normal hearts. So its presence in inferior lead doesn't always mean that it is a pathological Q until proven otherwise. Now, what are the causes of ST segment elevation? As our discussion from our previous discussion, we already know that ST elevation MI gives rise to ST elevation with convexity upwards or sloping upwards, and they are segment based. That next slide, please. Next slide. Next slide. Yes, this is the ST segment elevation causes. As our previous discussion, we know that in case of STEMI, this ST elevation is segment based. That is in anterior wall MI. The ST elevation is in V1 to V5. In case of inferior wall MI, ST elevation is in lead 2, 3 AVF. In case of lateral wall MI, it is the ST elevated in lead 1 and AVF. But if there is widespread ST elevation in anterior lead, inferior lead, lateral lead, we should be careful. We should carefully diagnose pericarditis because the management is quite different. If we thrombolize a patient of pericarditis, that may lead to fatal by leading to a hemorrhagic pericarditis. So, what are the features of pericarditis? Here, the ST elevation typically doesn't involve a particular segment. It is widespread, and here their character is they show concavity upwards. And two more important features we should consider. All leads show ST elevation except in AVR and lead V1, which shows ST depression. Please remember this. There is ST depression in AVR and lead V1. Along with this, if we carefully see, we may note some depression in the PR segment. And clinically also, we may see whether the chest pain is relieved in supine position and it is relieved a little bit on sitting and stooping forward. This is an indicator of pericarditis pain. Now, what are other causes of ST segment elevation? In left bundle branch block, in left ventricular hypertrophy, in ventricular pacing, in all these cases, we may find ST elevation in V1, V2, V3. And one more important thing is early repolarization. What happens in early repolarization? There is ST elevation commonly in V1 to V3 and sometimes in lead 2, 3 AVF. And in hyperkalemia. In hyperkalemia, we know that there is tall tented T wave Along with that, there may be ST elevation in V1, V2, V3. Now, extent of infarct. Is it possible to say how extensive the infarct is from the ECG? Next slide, please. Yes, it is possible. How? If the summation of the ST elevation in V1 to V6 is more than 12 millimeter, it indicates an extensive anterior wall lemma. Whereas if the summation of ST elevation in lead 2-3 AVF is more than 7 millimeter, it is an indicator of extensive inferior wall lemma. Next slide, please. Now I was telling about early repolarization. We know that the ST segment is the earliest change of repolarization of the ventricle. If repolarization is early, then ST starts early from the descending limb of the R wave. Okay. It is found normally in 50% of athletes. And a common mistake in critical care is to thrombolize the patient of early repolarization who comes with chest pain. So we should very carefully exclude early repolarization from STEMI. Here, T wave is always upright, never there is T wave inversion. And we should check for higher cardiac enzymes, echo, and then only thrombolize if the patient is young and if we have a doubt that it may be a case of early repolarization. Now, previously thought to be innocuous, the early repolarization syndrome, especially the inferolateral variety, may be related to sudden cardiac death due to idiopathic VF, though the actual risk is very low. So we should take the history of sudden cardiac death in his family or a history of syncope in that patient, etc., to think about this. Next slide, please. Next, please. Next, please. Yes. Now, how do you diagnose tall T wave and its cause? We know that the two important causes of tall T wave, one is hyperkalemia, where we also get ST elevation in V1 and V2, which may mimic an anteroseptal wall lemma. So what is the character of the T wave? Here the T wave is tall, tented, peaked, pointed, and symmetrical limbed. Both the limbs are symmetrically raised with a narrow base like a arrowhead. But the ischemic T wave are asymmetric and have a gradual sloped ascending limb with a rapid downslope with a broad base. And very easily we can differentiate by an ABG if we get high potassium level and the typical sign symptoms of ischemia is absent here. And there is history of CKD or drug intake of ACE inhibitor, ARB, etc. points towards this. Next slide, please. Here you see the picture of ischemic tall T on the left side, the gradual ascending limb with a rapid downslope with a broad base, and on the right side you see the hyperkalemic T wave, which is narrow, symmetrical, both the limbs, and pointed with a narrow base. Next, last slide. This is pseudo normalization of T wave during chest pain. I cannot resist to end my slide presentation before showing this slide, because many times from emergency we get a call that said the patient is giving the history of typical chest pain and etc., but the ECG is showing normal. But what we may see that his previous ECG before chest pain is showing ST depression or T wave inversion like this, showing here. And after the chest pain is resolved, again the T wave is showing inversion. This is this is called dynamic changes of STT, and this is very important. They should be examined very carefully, and NSTEMI or STEMI should be excluded. Thank you very much for your patience hearing. Thank you all.
Partha De, very nice speech by you. You have almost all almost covered all the points. So I think there are certain points which I should like to cover. How to diagnose the ST elevation MI in nutshell? First of all, one should see the inferior leads. If the inferior leads are showing the ST elevation in contrast to the acute MI, ST elevation MI, then you compare the 2 and 3 and see the also the V5, V6. If the lead 2 is having the more ST elevation compared to the lead 3 with the VI, V6 ST elevation, you must say it is a left circumflex. Otherwise, the reverse is true with the case of the right coronary artery occlusion. But in right coronary occlusion, if you see the apart from the inferior MI, if you see the ST elevation over the lead V1, you should have a strong suspicion, and you should have the right sided chest explosion as well. It will solve the problems. And if there is an inferior MI with the say V1 to V6 involvement, like the rep artery involvement, you should accordingly deal with. So inferior MI occlusion is a very much pointer, is a very good pointer to the sites of the occlusion where it is existing. And you compare the lead 2 and lead 3 as well, both the together. In posterior MI, when the lesions are not obvious from outside, from the front, then you should see the V1, V2, V3 just the reverse way. Yes, there will be tall R wave instead of the deep Q wave. ST depression will be there instead of the ST elevation, and the T wave will be tall. The T wave sound will be positive instead of the T wave inversion. Like this way, you should proceed on. So these points are very important. I should always ask the students to see over the inferior leads first, and then correlate the inferior leads finding with the chest lead findings. And that's whenever need that you should explore the right side leads. One. And the second point is very important, pseudo normalization of the T wave. Very important point. You have nicely dealt with, nothing to say further on. And one fundamental part of that is what are the sequences, how they produce the sequences in ST elevation and MI. If there is a epicardial, one formula is only there. If the current flow is towards the exploring lead, it is a positive wave. Away from the lead, it is a negative wave. So in the epicardial sort of the injury, say epicardial injury in the case of the major coronary artery epicardial involvement, then the ST elevation will be above, will be upward. So the upward ST elevation will indicate the epicardial injury. While the depressed ST elevation will indicate the subendocardial injury, because subendocardial is the part wherein the vascular vessels are being compressed much. So that part will be expressed as a ST segment depression. Apart from that, if the case of the acute ST elevation MI, you see that the necrosis has occurred. Myocardium, so there is no dead tissue, window reflection will be there. So Q wave, instead of the positive RV, you will find a Q wave, the next phase. And already gradually, ST elevation will be not remaining as such, ultimately replaced by the Q wave. And T wave will inversion will indicate the ischemic changes. So all depends. So first, my suggestion to all of you is just to correlate the findings pathologically, if possible. Just that will last, will form an everlasting impression. And I thanks a lot, Dr. Partha. Sir, you have very nicely explored all the things. मिजाज हिंदी में आप से मिजाज खुश हो गया सुनकर. Thanks, doctor.
As time is only 20 minutes, there were a lot of things to say, but when we will have some more opportunities and we'll allow a few more time, we will have opportunity to tell some more things.
Yes, sir, I do agree with you, but you are fortunate enough to miss the second speaker, so don't you have got the extra time in addition.
So I may add two more things. At times, we have the history of typical chest pain, high cardiac enzymes, ECG is showing normal. And on echocardiogram, we see only there is regional wall motion abnormality on the right ventricular free wall. Why it is that? After coronary angiogram, we frequently see that these are the cases where left circumflex artery is the dominant. That means the posterior descending artery arises from the left circumflex artery, and RCA is the non-dominant branch. That means it doesn't have the posterior descending artery. So in case of right coronary artery occlusion, when it is a non-dominant artery, there may not be any other change in ECG, but only the ST elevation in V1 may or may not be present. But if we take the ECG on V3R and V4R, that will show ST elevation. This is very important. So if we don't get any change, but typical chest pain, cardiac enzyme is high, do an echo, see whether the right ventricular free wall is moving or not. That indicates MI of right coronary artery in a non-dominant right coronary artery. And the similar thing we may see if there is an occlusion of the non-dominant left coronary artery. What happens there? If a non-dominant left coronary artery is obstructed, because in that case, posterior descending artery. So in that case, the can you please mute the sound? Can you please mute the sound? Yes. Now, in that case, if the right coronary artery is the dominant one and left coronary artery is the non-dominant, and there is obstruction of the left coronary artery, then only the posterior left ventricular branch is affected, and there we may say there we may see only the tall T wave in V1, and that should be considered, and we may take the help of an ECG on V8 and V9 leads, that is on the back side just below the scapula, which may show the typical changes of ST elevation MI. That is a pathological cue with ST elevation and T wave inversion. These two things we should keep in our mind. Thank you very much.
Comments from Dr. Anuradha ma'am, Dr. Deenbandhu Sahu.
Yes. Very nicely explained. Really grateful to Dr. De, and eloquently explained the key things to diagnose a case of coronary artery disease, and the session is really helpful and informative. Thank you, sir.
Dr. Anuradha ma'am.
Thank you very much.
Yeah, good evening. Really informative and good evening, and
Good
certainly
evening.
revision for all of us. So whatever small queries we have, we could clarify. It was an excellent session. Thank you.
Any other comments for Dr. Partha? Then we move to the next session.
Any significance of ST depression?
Yes, sir.
Hello.
Yeah, there is a question from Dr. Sanjay, sir.
Yeah.
Is there any significance of ST depression? Many a times ST depression we see without any symptoms, and it is said that it's a sign of ischemia. Patient is asymptomatic at that time. So when would you consider ST depression as a significant?
See, there are a lot of things about ST depression. There are a lot of causes which may give ST depression in ECG. There are a lot of non-ischemic causes. So we should consider all these. We may get ST depression in LVB, we may get ST depression in LVH, we may get ST depression in test lead, we may get ST depression in lot more things. So in case of only ST depression without the presence of any chest pain, we should investigate in the line of NSTEMI and unstable angina, and if we see that these things are negative, that means the cardiac enzyme is normal, we can exclude it as a case of NSTEMI. But in case of unstable angina, as we know that the cardiac enzyme may be normal, and if the sign symptom is typical, if there is history of angina on exertion, we may go for CAG or CT-CAG as well.
Thank you.
Sir, how to differentiate between the RBH and posterior MI?
Yes, this is a very important question, because in case of posterior wall MI, we are getting tall R wave in V1. And in case of right ventricular hypertrophy or in right bundle branch block, we are getting tall R wave in V1. So these three conditions should be differentiated. First, sign symptoms of chest pain is required. If there is no sign symptom of chest pain, we may not consider it as a only a case of posterior wall MI first. And only a case of posterior MI, as I told you, this is possible only if there is a block in the left circumflex artery, which is a non-dominant one. And in case of right bundle branch block, sorry, if we have some ST elevation in lead 2-3 AVF, along with that there is a tall R in V1, then it is an indicative of obstruction of the left circumflex artery, which is dominant, along with the involvement of the posterior valve. But in case of RBB, along with the R wave in lead 1 and AVL, there should be wide S, the presence of wide S in lead 1 AVL and V5 V6. But in case of right ventricular hypertrophy, what happens? We should get always right axis. In the absence of right axis, we should not stamp a case of upright R in V1 as a case of right ventricular hypertrophy. So as you have asked, how could you differentiate? The differentiation by ECG is you will get other signs of RBB, that is either a tall upright R or RSR dash in V1 V2, along with wide S in lead 1 AVL and V5 V6, which is absent in case of posterior wall MI, where there is tall R in V1. And very important thing, to exclude it only by ECG is to take an ECG on the back side, that is below the right scapula. It is called lead V8 and V9. If you see the reciprocal changes of tall R seen in V1 in this V8 and V9, you will be sure that it is a case of posterior wall MI. It will be opposite to that. Here you will see tall T. There the counterpart of tall T will be the deep Q. Here you will see ST depression. There the opposite change will be the ST elevation. And here you see upright T. There you will see inverted T. Because from the posterior side, if the posterior wall is necrosed, the vector will pass from the front side to the posterior side. So the posterior lead will show the positive leads. It will show the ST elevation, whereas the anterior leads, that is the V1, in respect to posterior wall, is showing the ST depression. So in a case of posterior wall MI, you will see upright T in V1, but on the back side, just opposite to V1 on the back, if we take an ECG below the right scapula, we will have Q wave, which is the counterpart of tall T.
Thank you. Excellent presentation, Dr. Partha. Dr. Jagnany, can we move to the next session?
Sure. We are already running late. Thank you so much, Dr. Partha. That was really a detailed discussion. And thanks for the wonderful participation from all the speakers. So kindly accept the certificate. Dr. Khetan sir, Dr. Dinbandhu Sahu, Dr. Rajni ma'am, Dr. Umesh Kashyap. Also, Dr. Anuradha ma'am, Dr. Amar, Dr. Manav and Dr. Chitrali Singh for chairing the session. Moving to the next session, which is from Dr. S. Venkatesh Prabhu from Dharapuram. He is clinical cardiologist and he has received awards from IMA called Muruthuva Nachatram, and he is also member of FISC. To chair the session, I invite Dr. Pragnesh Vacharajani, who is medical officer at ESIS Ahmedabad. He has been a speaker at various conferences, founder of FPECGCON, Honorary General Secretary of FFPAI, Secretary FP Forum, Gujarat, and President of IMA. Also, Dr. Jaishankar, Dr. P. Mohan, and Dr. Ashwin S. from Ranchi, Coimbatore, and Bangalore, respectively, as clinical cardiologists. Dr. Ashwin S. is clinical cardiologist at Shriya Cardio Diabetes Care and recipient of Presidential Award called Rashtrapati Scout. With these words, I request Dr. Prabhu to accept the esteemed speaker award prior to the session as a medallion, memento, and certificate. With these, I request him to kindly take over, Dr. Chairpersons to kindly take over from this point. Dr. Pragnesh.
Thank you, Dr. Jagnany, for kind words. And I first would like to congratulate FPA Ranchi. Excellent clinical discussion going on. And it is always a learning experience when we keep on learning, keep on listening to the learned speakers. Now, the next topic is non-ST elevation, non-STEMI equivalent. And as Dr. Jagnany has already introduced, it will be taken by Dr. S Prabhu Venkatesh. I will request Dr. S Prabhu to kindly start the session, and we'll have interaction at the end of the session. And I also welcome my fellow co-chairpersons and all the members of FFPAI across India. Thank you. All yours, sir.
Beautiful. Good afternoon to all of you. Good afternoon, everybody.
Good afternoon, sir.
Hema, good afternoon. Can you share the slides? Should I share my screen? Hema from Clarinet. Hema.
Yes, sir. Are you sharing the screen, sir?
Yeah. Do you have my slides?
No, sir. Your slides are not with me, sir. I have not received it yet. Yeah.
Okay. 1 second. One second. Are you able to see my screen?
So your screen is not visible.
সিনিয়র লোকেরা ছিল, আমি এটা না রেকর্ড করতে পারলাম না, তারা কি বললো লাস্টে রেকর্ড করা ছিল, তারা কি বললো
জামাটা ছেড়ে আসো।
Yeah, now?
Yes, sir. Your screen is visible.
Yeah, it is visible.
Yes, sir. So kindly change it into full screen, sir.
Yep.
Okay, thank you. So in the right hand side, in the corner, sir.
Yeah.
At the below of your screen. Yeah.
Beautiful. Before I go into the...
So sorry to interrupt you, sir. Your screen is not in full screen mode, sir.
Yeah, really? I can see here as a screen share. It's not coming?
No, sir. Your screen is visible, but it's not on full screen mode.
Let's see. This should be visible.
Dr. Prabhu, press F5.
What should I do?
F5.
Pragnesh?
Yeah.
F5.
F5.
Yeah.
On your keyboard. On your keypad, press F5. And you can change your slide on your screen.
Let me see. Okay, let's see how it goes.
Yes.
Anyway, I have beautiful two Dr. Pragnesh watching me. One as the chairperson, and the other one has been my IACP president last year. I have Dr. Jaishankar, chairperson from Ranchi. Dr. Mohan, I don't see him, but still, hello Mohan. And Ashwin from Bangalore. Thank you all, esteemed chairpersons. I think my slides, should go on well. And before I go into my speech of semi-equivalence through ECG, we had Dr. Yadav, we have Dr. Partha, and we had Dr. Kaitan really helping us out, and they were more or less covering my topic also. So, who are we going to get a ECG then? People will come with chest pain to us. Without chest pain, without agony, they won't come to you. So please do an ECG first of all. Okay, that is first. And when you first see ECG, if you don't see what Dr. Partha said, a STEMI, non-STEMI, now the terminology has changed. It has become occlusive myocardial infarction. I think most of us would have heard. Suppose if you aren't aware, I will send the slides to you or the topics to you in our webinar, speakers webinar. So STEMI is slowly, they say STEMI sometimes misses occlusive myocardial infarction. So this particular term, OMI, occlusive myocardial infarction for STEMI, and for non-STEMI, non-occlusive myocardial infarction. There should be some occlusion without which the patient would not have pain. So identifying what you are going to do with an occlusive MI or a STEMI, immediately you see pain. So previous speaker, Dr. Partha, had elaborated regarding anterior, inferior, posterior, lateral, and all that. So I will be talking about semi-equivalent. Pain is there, agony is there, but I'm not saying anything just like what Dr. Partha said. Classical ST elevation is not there. Classical ST depression is not there. So the traditional ST elevation criteria is not being met. 0.25 millimeters in 3 or 4 leads together. It is not there. So how am I going to recognize? This is my problem. So I'm going to help you out. What are the semi-equivalents to the best of my knowledge? So we all know what we can do over here. We have this classical ST elevation and V1 to V4, lead 1, AVL. So we can classically call it as an anterolateral MI, STEMI, and we can either thrombolize immediately if we are in a peripheral center, or we can refer him for a early PCI. Okay. So in the absence of ischemic ST segment elevation, or as we said, the dynamic changes, what are we going to do? The pain is severe. My advice is, before I come to the conclusion, please treat them. Start treating them. Be aware it's life and death. We've had many account of fibrillations, sudden cardiac death, waiting for the ECG to take a ST elevation MI. As Sir had said, even if it is there is a circumflex lesion, you get a normal ECG. Okay, so guidelines are there, prompt evaluation and emergent coronary angiography to save the life as time is matter. Okay, so I'll be talking about 4 mainly, and the 5th all of us know, 4 to 5 semi-equivalents. Okay, critical left main disease. So a 70-year-old male presented with chest pain. Here we can see classical elevation of ST.
Sir, slide is not changing.
Pardon me?
Sir, slide is not changing.
It's changing over here.
Just press next or arrow down.
I did so.
No, sir. Arrow down. Press arrow down.
I did, sir. It is not changing.
Sir, there is a TV-like symbol in your right side lower corner of your screen. Click it, so it will be a full screen presentation, and then you can change it, I guess.
75%. Very next to 75%.
Yes, yes, you can do full screen from there also. Yes, select full screen from there.
This is okay?
No, no, sir.
Ashwin, okay, I'll see. I'll do my best. I was just call my son. I think he should be able to help me.
Sir, you can see the person. You can see 79% written on the right side of the screen. Just click the button next to it. Just click the button next to it. 79% on the right hand corner.
There is a cop-like symbol, sir. Just click over there.
1 second, sir. I'll call my son. I'm not sure. 1 second.
No issue, sir.
Krishna, full screen రాలాసి నీ మాట్లాడుకుంటే పరిస్థితి
Just do the full screen, Toast.
Full screen.
Yeah. Oh no, just do it.
Sir, go to view. Go to view and ask. No, view. Sir, come down to the lower part. Very next to 75%.
Dr. Prabhu, to the your right base of your screen, you will read 75%. Just to the left side of that, you can click on the button. It will give you full screen. Yes, slide is changing now.
Oh,
yes.
Go back. Yes.
Yes, wonderful.
Yes,
Enter.
wonderful.
Yes, wonderful. It's moving.
Fair enough. I think you can start, sir.
Yeah. I'll try my best again, sir. Sorry for the inconvenience. Krishna, wait. Yes, moving?
It's moving, sir.
It's moving,
yes,
Dr. Prabhu, it's moving.
Yeah.
Yeah, fine. So,
70-year-old male.
Classical ST elevation MI, classical ST elevation seen in always the rejected lead AVR, which we always see the other way around. Okay. So the classical ST elevation is seen here, and there is some amount of depression in all the other leads. So very classical, showing left main. Okay. We'll be seeing the angio picture also. And here, are you able to see the classical AVR elevation with the red marker?
Yes, sir.
Okay, fine. So, especially ST elevation in AVL, please have a look at this AVL lead. Many a time, what we don't see in other leads, we can see it in AVL. If there is a change, please become alert. Okay, so here we can see a critical left main. in the angiogram. Another left main stenosis with ST elevation over here in AVR. Okay, lot of depression seen everywhere. That's 90% left main occlusion. Okay, now this is a case of 48-year-old male with chest pain. We don't see anything very, very inconspicuous ST depression or a mild ST depression in V1, V2, V3. Usually, we see an inferior wall infarction along with the posterior wall infarction. Here, you don't see the inferior wall, and we see only the posterior leads V1, V2, V3 with subtle ST depression. Okay, so this has to be kept in mind when a patient comes with chest pain and agony. Okay, so this is isolated posterior wall MI. ST segment significantly there is depression V1 to V3, and as the MI evolves, there will be upright T wave. Okay, so acute inferior posterior wall MI we have seen many a time. There is ST elevation in 2-3 AVF, and V1, V2, V3 there is depression. Once you thrombolize, this depression will come up, and this ST elevation will usually come down. ST segment will come down after thrombolysis. That's a good thrombolysis, good result. So, if it is isolated posterior MI, what are you going to do? So, as I said, when there is V1, V2, V3 depression, just flip the ECG the other way, see from behind. If there is ST elevation in V1, V2, 3, when you have flipped the ECG, it is pure posterior MI. Am I clear regarding that? See, V1, V2, V3, there is depression isolated. I flipped my electrocardiogram. You can see the V1, V2, V3 is inverted. There is classical ST elevation. This is one way how my teachers taught me to identify isolated posterior MI. Thank you. Next. So things keep changing. Okay, as you thrombolize, as you treat, once the patient becomes better. Coming to the third case, it's a 65-year-old woman with severe substernal chest pain. Okay, you can see classical, same similar type of, but there is no that depression with the V1, V2, V3, but there is a nice coving of the V1, V2, V3 lead. Okay, and there is some amount of T inversion in the V4 also. So this is Wellens warning. LAD lesion is there associated with changes in V2, V4. This classical ST changes or T inversion has to be kept in mind. I generally have photographs in my ICU for any time if the patient comes, it might be in the middle of the night, it will be in a postprandial state, or you'll be having your afternoon nap. Generally, the nurses will take a ECG and report to you. They say most of the time it's a normal ECG, so you can come leisurely. But the patient, if he comes at 3 o'clock in the afternoon or 3 o'clock in the midnight, it is definitely something to be worried about. Okay, so Wellens warning, we'll be seeing this is the classical Wellens syndrome where you see a minimal changes of the V1 and V2 T wave inversion. Type 2, you see this type of thing, and don't take it very lightly because this is going to change into a MI later on. So Wellens syndrome type 1, type 2 you saw, that is some amount of ST changes seen in the anterior lead. Okay, so most of the people, they this was the first ECG seen in the earlier part of the day. Slowly it becomes better. 1 month earlier it was absolutely normal, and previous ECG, now the presentation. Later, 1 week later, it has gone into a full-blown anterior wall MI. Okay, so this Wellens fellow had identified that this type of small significant change from the normal ECG in the anterior lead becomes a full-blown anterior wall MI in a week or a month or so. Okay, next. So 60-year-old male with chest pain. Look at this. We all have been seeing depression till now. Now this is a classical uptake after V1, V2, V3. Okay. This is D Winter sign. I saw a beautiful smoker. He was a driver of a bus. He was driving. He had severe pain. He just stopped the bus with the passengers. He came to me, and this was the D Winter sign. And I told them I'll thrombolize, but they had a known cardiologist nearby town. They said they're going for a primary. So because we knew this and we could identify it was D Winter and it was a semi-equivalent, he did well. So the pain, which was very severe, and it is proximal LAD occlusion. That is what I said. He was driving a bus. He stopped the bus with the passengers. He ran and came to me. So this was a story. So classical D Winters, this is the type of thing which you have to remember. You please make a photograph and stick it in your ICU so that you won't forget. Classical MIs are easily evident, and most of the machines which have an interpretation, they can identify. With subtle changes, which are always a doubt, where you can think about hyperkalemia states and all that, can also be a DD. But last Dr. Partha had said very different methodology of hyperkalemia wave, and classical ST elevation are the ischemic waves. Okay, so this is the classical D Winter sign, and this is a gentleman with LBBB, and we all are pundits in LBBB. Normal LBB, nothing to worry. People above 35, you can have left bundle branch block, but you have to check an echo and go along. People coming with LBB, echo showing jerky septum. If sometimes if it's an elderly person, it's a normal thing. If you thrombolize, you take an urgent method. If it's a doctor's family, you are worried, you are tense, and you thrombolize, you will lead into intracervical hemorrhage. So this has happened to one of my colleagues, and left bundle branch block, go with because many people have LBBB unless until you have an older ECG to compare. So LBBB with ST changes, kindly go ahead with the according to the pain. But most of the elderly people have left bundle branch block. With ST changes, you can treat it conservatively, put them into an angiogram, coronary angiogram, then they will decide. Hurry, if you're going to treat an LBBB, you might land up in trouble for elderly people. Okay. So in conclusion, we talked about the forgotten lead or the left lead AVR with a classical ST elevation. It is left main. Next, isolated posterior MI. If it is associated with inferior, it is easy to diagnose. If it is isolated, just mild ST depression in V1, V2, V3, just flip the ECG and see, and go along with the other parameters, diagnose as it as isolated posterior MI. It is also semi-equivalent. Third is Wellens warning. The V1, V2, V3 slight depression with an arrowhead type of T. It keeps on changing and becomes a full-blown MI later. Be aware. Fourth is D Winter sign, which I said hyperacute T waves and ST depression. The classical D Winters we see accordingly. Okay, and this is our LBBB with ST elevation, which will prompt you to treat with good support, because LBBB will suddenly you thrombolize, as I said, it might land up, especially in elderly people. Okay, so in conclusion, remember this semi-equivalent to save the myocardium as time is muscle. Whenever you are in doubt, we all have WhatsApp groups. Discuss with people. You can ask your person whom you are referring what type of thing we are in doubt. And whenever you have a wonderful ECG with classical changes which you have treated, please preserve them. I usually stick on to it in my ICU so that I can recognize this D Winter, Wellens, infero-posterior and all that AVR, it is usually identifiable. This winters, the winters and well, sometimes you might miss. So as I had suggested, patients won't come to you simply. Only when there is pain, especially women, they come to you with a lot of. While we are watching, I have seen so many women getting arrested. So be ready, be prompt, immediately attend to them, and do your best. I know we all are good in treating MI, and I thank my chairperson. I thank Dr. V K Jagnany, and I thank the Gujarat and Jharkhand family physicians for their time. Okay, time and thing. If there is anything, we can still discuss. If there is any question, please ask me, please. Sorry about the presentation, the hitch and all that. Gentlemen.
Thank you so much. Over to Dr. Pragnesh for his remarks.
Thank you, Dr. Prabhu sir, for that elaborate interaction and giving us a lot of good clinical tips about the identifying a sign. And I like the idea of keeping the photos at the in ICUs and at critical places, so that can serve as a reference whenever something unusual comes up. But as we clinician always says, the sixth sense or the clinical acumen of classical chest pain along with ECG changes is the thing that which makes all the difference. And along with this, so thank you for giving us the good clinical pulse and tips. Thank you, sir.
Dr. Ashwin.
Yeah. See, for the listeners, we have, as Prabhu sir said, a lot of causes for ST elevations, but we should know non-cardiac causes of ST elevation, also non-cardiac causes for ST depression, covering both the topics which were done earlier, especially in young males. You know, we see it's all called as male pattern among the 30 thin, tall males. We can have this ST elevation V1 to V3. Again, history is very important, no doubt about it. We can also see this ST elevation pattern in the early repolation. We all know. Sir had discussed about left bundle branch block. Then we can also see such elevations in, case of pericarditis, myocarditis, even in case of significant hyperkalemia, or we can see it in case of Brugada syndrome, pulmonary embolism, also post-cardioversion for reasons, things, and again, vasospasm. All these things we can see in ST elevation. This is non-cardiac causes of ST elevation in these patients. Again, when we come to ST depressions, we can see in case of even in LV hypertrophy or RV hypertrophy, we can have an ST elevation or ST depressions. Again, sometimes they can come with gastritis, but again, always Sir Prabhu sir said it's time is muscle here, but still we should keep in our mind what are the other causes of this ST depressions. Could be due to hypertrophy, RV or LV. It could be because even central nervous system, anybody with the CVNS, they have an hemorrhage or an infarct, they can come with STT changes. So here now there will be always a question whether to treat the myocardium or there is another cause. So here clinical acumen is very important. We need to consider everything, clinical examination, what is the complaint, and then go with it. Even in case of electrolyte imbalance, especially hyperkalemia for ST elevation, hypokalemia for ST depression, then we can have, as sir said, LBVB also is an important point. And in our practice, we see among females, we see a lot of ST depressions. It's very common in females with normal coronaries. So I would say that these are the non-cardiac causes for ST elevations and ST depressions. This is just an add-on message to the sir, what Prabhu sir said.
Thank you. Thank you so much. We move on to the next session. Requesting Dr. Prabhu to kindly accept the memento and certificate and the medallion. Certificate for Dr. Prabhu, our chairpersons, Dr. Pragnesh, Dr. Jaishankar, Dr. Mohan, and Dr. Ashwin. Thank you so much. We move on to the next session. To chair the session, we have Dr. Hiren Mehta, who is past president of GSFPF and National Medicos Organization, founder of Gandhidham FPA. Also, we have Dr. Alka Goalre and Dr. Manish Kedia from Ranchi and Bhopal, respectively, clinical cardiologists, and Dr. Rupam Sharma from Jaipur, who is clinical cardiologist and head of department at Eternal Hospital in non-invasive cardiology, emergency and trauma, and founder and president of Jeevitasha, and he has served as president of ISCC and founder secretary of Rajasthan chapter of ISCC. The session will be taken by Dr. Nishant Kumar. To introduce the speaker, I request Dr. Hiren Mehta to kindly take over.
Good afternoon, everybody. First of all, I would like to congratulate Ranchi FPA for organizing such a wonderful seminar on ECG. It is very, very useful to all our physicians. And I welcome all delegates. Now, our next speaker is Dr. Nishant Kumar, consulting clinical cardiologist at Tata Cancer Hospital, Muzaffarnagar. His topic is P-wave. Usually, we all discuss about only ECG and acute MI. Now, he will introduce the importance of P-wave in clinical practice. I welcome Dr. Nishant Kumar. Please, sir, hand over to you.
Good afternoon, everybody. I hope the presentation is not very basic for all the audience, because I have kept a very basic presentation, because I was aware that it was a very basic presentation. So why did I choose this topic to yeah. Am I audible?
Yes, sir.
Hello.
Yes, sir, audible.
Thank you. Yeah. Thank you very much. Yeah. Okay. So why did I choose this topic? So generally, whenever there is an ECG conference or anything, the one thing which gets discussed is an acute myocardial infarction, and is perhaps most of the times the ST segments. The ST segment, it gets more and more importance, and it is due for importance because it has significant clinical advantages. But when we talk about arrhythmias at the level of primary physicians, not much is done by the primary physician, because if the patient has a severe bradyarrhythmia, the patient is referred to the cardiologist for a pacemaker, to an interventional cardiologist for a pacemaker, or if the patient has a tachyarrhythmia, they generally share the ECG to its colleague, or probably start the appropriate antiarrhythmic, and probably either a beta blocker or an amiodarone. These are the two choices most of the times family physicians have. In some cases, they also start lenoxin, which may not be appropriate according to therapy. So generally, most of the time when you are starting or reading the ECG, we generally begin with P wave, and we tend to give least importance to this particular wave. The reason we give least particular importance to it, perhaps it has the smallest amplitude of all the waves, and it's the ST segment which captures our imagination. But as we dwell more deeper into ECG and make our understanding better, we realize it is actually the P wave which controls the entire ECG. Because when we delve in the realm of arrhythmias, tachyarrhythmias, bradyarrhythmias, when we do EP studies, it is the P wave which is the holds the maximum importance. And though it is not very important, the family physicians should know everything about the P wave, but there should be some important detail they must be aware of, because that may help them in their clinical practice. So beginning with the very basic, it is something very important for all of us to understand. The cardiac muscle is a very different kind of muscle altogether. The entire cardiac muscle has a capacity of atomicity. That means every single cell of the cardiac muscle has a rhythm of its own. It's like a series of drummers who are beating together, and they all beat together. The whole structure is beating. Even there is no control over it, there is atomicity. There the structure moves around. One of the largest sets of cells which are located around the inferior and superior vena cava, which forms the SA node, depolarizes or discharges at a very higher rate, which is around 70 to 90 per minute. And because their discharge is the highest, they control the entire mechanism of the heart. They control the entire rhythm activity of the heart. So you can say the SA node is the chief drummer. It drums the loudest, and so it is heard the loudest. Other structures are not heard, and that particular node's activity is seen on a small P wave, which is seen on the ECG, which is called the P wave. So you can understand it's a very small structure making a large noise, but has a very small impact on the whole of ECG. But it plays a very key role in detection of arrhythmias and finding of any tachyarrhythmias or bradyarrhythmias. So when we talk about P wave, I already mentioned where is the P wave located. Now, when we study the structural anomalies of atrial fibrillation, a lot more information and a lot more emphasis is given where actually the SA node is located. When we go to the realm of electrophysiology, they tend to map the origin of SA node, where the SA node or the aberrant rhythms are located. So those mapping is very important. So generally it is located somewhere near the SV inferior and superior vena cava. It is important to understand that there is not one cell. It is actually a group of cells. So there are multiple cells, and these cells are supplied by a blood vessel, which is from the right coronary artery, the left dominant. They could also be given from a branch from the left circumflex artery. Most of the time in a right dominant system, they are supplies from the right coronary artery. So they receive their blood circulation from that. The SA nodal artery, which supplies the branch to it. So this is the place where the SA node is located somewhere on the top of the right atrium, and it is where the notes or the rhythm of the heart is generated. Very important for us to understand. So generally, when we start the ECG, it is the first positive deflection we see on an ECG. Whenever you look at an ECG, it is very important to find the P wave. You may be focused more on the ST segment. You may be focused more on the where there is ST elevation or not. Generally, that is what our intention is. Whenever we are handed over an ECG, we tend to look after where is the ST segment elevation. Is there an ST segment elevation, depression? We tend to put our images first on the ST segment because the QRS is the largest dominant wave. We tend to put least information on the P wave, and it is a common problem what we do. It is a very good practice always when you get an ECG in your hand, look for the P wave. If you do not find a P wave in your hand, always think, where is that P wave? Why is P wave is not there? So always when I remember me and Dr. Vinny, we were working in spots, we were working in Apollo, and most of the times we used to get ECG. Our physician, our hero department, to Neeraj or Deepak would always ask us to get an ECG. Always the ECG is clear. The ECG should not have any aberrant marking. There should be a good clean ECG. And nowadays we have LCD screens. We can see good ECGs on our screens. So always find the P wave on the ECG, because it represents the atrial depolarization, and always see how many seconds does this P wave last. Normally it should last for 3 small squares. If you're not considering of seconds, it should be generally less than 120 milliseconds. So always look for the ECG P wave. So now what kind of P wave should this be? Now generally when we talk about axes, we always talk about P wave axis, but if the QRS axis, but it is the P wave axis is also very important. Normally the P wave axis is around 0 degrees to 75 degrees. Now always remember the P wave is located on the in superior vena cava. So it will always be positive in lid 1 and lid 2, because the lid 1 it will be 0 degrees and it is located by the lid 1, and lid 2 is between the right arm and the left leg. So it will always be located at the topmost form, and the discharge is from the SA node to the AV node. So the P wave in lid 1 and lid 2 will always be positive, and lid AVR, which is again called the misnomer lead, the lid P wave is always negative. It is very important to just keep this in your mind. The first thing when you get an ECG in your hand, look at the P wave. It is of normal size. Look lid 1, look 2, lid 2. Look at the lid V1 also, because P wave is positive. There also it could be biphasic, but lid 1 and lid 2 always look for the P wave. P wave is generally best visualized in lid 2 and lid V1. It is where it is most best visualized, but always ensure the lid P or the lid P wave is positive in lid 1 and lid 2, and it is negative in AVR. It is very important to do this, because if you do that, we'll tell you the importance in the next slides. So this is a very important slide. Now this had happened to me also, and it happened to a lot of colleagues who are working in different hospitals. You certainly find this kind of ECGs where there is an positive QRS complex in lid AVR, and the entire lid is negative. And this is the patient which has a dextrocardia. Many a times when you are working with the staff, those who are new, they will take, you have to ask them, have you put the electrodes on the right place? There are many times staffs will put the electrodes on the left side, they'll put it on the right side. Though it appears very silly, but it tends to happen quite often. And it tends to happen in many centers, even in bigger centers. So always one of the important part of finding the P wave axis or looking for the positivity of P wave is to see whether the ECG was acquired correctly or not. So look for where the patient has dextrocardia or not. If you see the ECG has been acquired correctly, and if you find a positive P wave in lid AVR, always suspect dextrocardia. So what is the normal characteristic of P wave? Normally, the P wave has a smooth contour. It is monophasic in lid 2, and it could be biphasic in lid V1. The duration is generally less than 120 milliseconds. And the amplitude is something, again, we put very least important to. The amplitude of P wave in the limb lids should be less than 0.25 millivolts, and in precordial lids should be less than around 1.5 millivolts. So it is a small lid. Generally, atrial abnormalities, when you look for P wave, always look lid 2, 3, and AVF, and lid V1, where the P wave is perhaps the most prominent one. So normally what happens when you have P wave which is higher in size, we call that the P wave or P pulmonale. The P wave is again divided into two halves, the right half and the left half. The right half signifies to the right atrium and the left half signifies to the left atrium. So if the right half of the P wave is very high in size, that means there is a right atrial enlargement. If the P wave is wide in size, that means there is a left atrial enlargement. So this is how you should picture it in a head. The P wave, we should look at the two atrium. If you look at the two atrium and think of them a big M, and you see if the left atrium is a bigger in size, so that means the P wave will be M in size. And if you see the right atrium is located more anteriorly, so if the P wave is more upright, that means it is a P wave or it is a right atrial enlargement. Now, P atrial enlargement plays a very important role when you are diagnosing in a patient with pulmonary artery hypertension, especially in COPD patients. When you see COPD patients or see patients with congenital heart disease who have pulmonary artery hypertension, or patient with congenital heart disease, they have pulmonary artery hypertension. This prominent P wave or tall peak P wave plays a very important role in our diagnosis whether the patient has a pulmonary artery hypertension or not. All right. Now the P wave could be biphasic in lid V1, so it is important to look for the negative deflection in that. The other thing what we look for after the P wave in the inferior segments. Now in the inferior lids, if the P wave is originated from a lower point, suppose the P wave was supposed to, suppose the normal SA node is not functioning, and the P wave has originated, or the atrial depolarization has originated from a place below the SA node. So you will find in the normal lids, the P waves are negative. So that means this is what you're looking at is a junctional rhythm. So here it is very important, because if you look at the ECG, if the person just goes through the ECG, you may not understand this QRS complex. Let's say it's a normal P wave, just go through if you do not put more attention to where the location of the P wave. All right. So I've talked about right atrial enlargement. With the right atrial enlargement, you will have the tall P wave. There's an anomaly called the Epstein's anomaly. The Epstein's anomaly, there is an atrialization of the right atrium. That is, the right atrium and the tricuspid leaflets actually move forward. So you and Epstein's people have long survivors also. If I BP patients, those who are 75, 35 years old, people who have Epstein's anomaly. In these patients, you will typically find large prominent P wave. In patients with COPD also, sometimes you will find large P waves. So it's very important to look for these tall P waves, because they will suggest atrial enlargement, right atrial enlargement, or may also suggest pulmonary artery hypertension. Generally, if there is a right atrial enlargement, we call that P wave the P pulmonale. It is best visualized in lid 2, lid 3, and AVF. So this is a picture which we have compromised, which is the normal P wave which you see in lid 2 and lid V1. Right atrial enlargement, as you will rightly see, the right atrium has become enlarged because the right atrium is located more anteriorly. So the right atrium has gone back. The left atrium is located more posteriorly. So if the left atrium enlarges, it will enlarges backwards. So it presses upon the esophagus and it presses upon the rectal nerve. So it may cause dysphagia. It may cause difficulty in swallowing. So you have the distal part or the distal part of the left side of the P wave is enlarged. When there is biatrial enlargement, you will find both the P wave is also tall and it's also wide. So it's important to look at, remember this morphology in your head. Once you see this morphology, it's easy for you to understand. Now, one of the commonest causes for right atrial enlargement is chronic lung diseases. It is very important for patients with cor pulmonale because if you in your regular practices see a lot of COPD patients, and one of the important things what we have noticed, or you notice when you do practice, when you see patients irregularly falling above and you see the patient stop responding to bronchodilators, you'll see the patient is going into heart failure, right heart failure also. So when there is onset of pulmonary artery hypertension or there is requirement of cor pulmonale, you'll see there is development of this tall P waves. So these P waves will also not also help you in cardiology, but will also help you when you are practicing your respiratory medicine, and also will help you in catering your treatments. Sometimes identifying congenital heart diseases, P wave plays a very important role, especially if you're looking at pulmonary stenosis and tetralogy of Fallot. Sometimes it's very difficult to make out whether you are suffering from an isolated pulmonary stenosis or you're dealing with tetralogy of Fallot. So when you see a P wave and you find tall P waves, always suspect the child has some congenital heart, either a pulmonary stenosis or a tetralogy of Fallot. In cases of diagnosis of exclusion where you have not found out any cause, especially in primary pulmonary hypertension, there could be an enlarged P wave or a tall P wave. So look for these P waves. Tall P waves are very important, and if you do not have any of these causes, always consider Epstein anomaly in your diagnosis. Though most of the times, then you will not tend to put more attention to it. What generally happens is the patient comes, he is been evaluated and goes for an echo, and suddenly when you do an echo, you find all these changes, and then you come back to the ECG and look at the ECG. Though it is the normal thing that occurs, but if you're working in a low resource setting and where you have not any work, and if you're just looking at the ECG first time, try to look at these features probably and try to predict better. So that will help you much. So this is a typical ECG of P pulmonale, which you can see that typically tall amplitude of P waves. Okay, which is a typical P wave amplitude, and you can see you can also make out there's RV strain. If you can make out there's some strain pattern here. The ST segment has gone down, suggesting of there is evidence of pulmonary artery hypertension, which you can make out here. The PR segment has depressed. So this tall P wave with depression of PR segments suggests that there is pulmonary artery hypertension. Pulmonary artery hypertension is, though there is no right ventricular, right atrial hypertrophy, right ventricular hypertrophy here, but this strain can be made out. All right, talking about the left atrial enlargement. The left atrial enlargement is very important to assess nowadays because a large number of patients who are elderly come to us with atrial fibrillation. And when they are having a normal sinus rhythm, when you do an ECG and if you find there is a left atrial enlargement, you can virtually predict and tell them that there could be chances of atrial fibrillation. Many times, many elderly people, in our practice, we see have proximal atrial fibrillation, that they will be perfectly all right and they are not willing for a Holter. And suddenly when you do an ECG, you don't put a more attention to the left atrium, and suppose somebody has put attention, you find there's a left atrial enlargement and this is a particular sinus rhythm, there could be a chance that this particular elderly gentleman would be having a left atrial enlargement and having proximal atrial fibrillation. And so that you can detect early, and when you detect proximal atrial fibrillation, you can start oral anticoagulants as early as possible and prevent them from having strokes. So here detection using P waves, using this small P wave could save somebody's life. So always put more emphasis on the P wave. So I said the second part of the P wave detects about the left atrial enlargement. To look at the P wave, and we call this P wave as the P mitral. It is commonly enlarged in mitral stenosis, which is the most common rheumatic heart disease we see. But on the other spectrum, it is also seen enlarged in the patient with chronic atrial fibrillation, those who have risk for atrial fibrillation. All right, I think it's already shown this chart here. Okay, this is what we have already discussed it. We have already shown it. Okay? All right, Now, there are some isolated causes of left atrial hypertrophy, and though it is in isolation seen in mitral stenosis, it could also be seen with left ventricular hypertrophy in systemic hypertension, in patient with aortic stenosis, mitral incompetence, and hypertrophic cardiomyopathies. Okay. Talking about the biatrial enlargement, you will find both the P wave is tall and also there is wide. Now, this is the criteria for the biatrial enlargement. If you can just remember it, you will in lead V1 you will find a biphasic P wave, which is initial positive deflection of more than 1.5 millimeter, and a terminal deflection of 1 millimeter deep, and a negative deflection of less than 40 millimeter. Just remember it in lead V1 and lead V2. In V2 you will find a biphasic P wave, and in lead V1 you will find a biphasic P wave, which is tall and wide and deep. So that would give you an enlargement impression that is a biatrial enlargement. This is the good example for a biphasic P wave enlargement showing tall P waves. I think we can all mention, we can make it very clear. Now this is an example of biatrial enlargement that you can look. Is a biatrial enlargement with left ventricular hypertrophy also. Get clear. All right. Now, what the important role P wave plays in identification of atrial arrhythmias? Always look at the P wave. See the P wave morphology here, and the first P wave is of normal morphology. Certainly, there is a secondary P wave whose morphology is completely different. So this is a premature atrial complex. So even though it is not a diagnosis which is of more importance than the cause patient, the patient of premature atrial contraction generally comes presents to you. There will be generally young women who presents to you with complaint of feeling awkwardness, occasional arrhythmias, occasional palpitations. So it makes you a better physician when you detect them early. When you see these PSEs, you understand this patient is either consuming more caffeine, and there's a role for giving beta blockers here. So that is a very important thing. So it's very important for us to identify the P wave, identify that there is a reason of premature atrial contraction. They may also require EP studies and other things, but generally they respond well to beta blockers and they're given well. All right. So they're usually normal, irregular, premature, highly, and they are prolonged P-log interval. Atrial tachycardia. Atrial tachycardia are very important because atrial tachycardia are commonly seen in young children who have heart failure. I think we have seen them 2 to 3 more patients who are young children who have been diagnosed to have rheumatic heart disease and treated with lanoxine and so many drugs. And atrial tachycardia is very resistant to amiodarone. They don't respond to amiodarone. So it is very important for a physician to diagnose atrial tachycardia. And though it is very difficult, one of the hallmark feature is the morphology of P wave, where the P wave is upright or down. If you see a downright P wave in lit 2, always suspect atrial tachycardia. That is the catch here. So if you find a negative P wave in a lit 2 instead of a positive P wave, always suspect atrial tachycardia. Because atrial tachycardia do not respond to amiodarone, and people think it's an atrial fibrillation or patient has atrial and they prescribe them amiodarone, they prescribe them lanoxine, they prescribe them so many things. Atrial tachycardia is only get treated by EP. So it's very important that we identify atrial tachycardia very early. All right. So when the real atrial tachycardia is going on, you may not pick it out. It's very difficult to pick out when the atrial tachycardia is going on. All right. Multifocal atrial rhythms are again very common in patients with COPDs. Here you see 3 morphologies of P waves, and the RR interval is also varied. Multifocal atrial tachycardia is again misconstructed, or people relabel them as atrial fibrillation, because many a time when physicians look at the ECG, they don't tend to look at the morphology of P wave. They just tend to look at the QRS complex and say it's an irregular QRS complex, and then the patient with the COPD is put on an oral anticoagulants. So without the physician assessing it, the patient has a multifocal atrial rhythm or MAT. So it's important to make those differences, because multifocal atrial tachycardia is of different etiology, and atrial arrhythmias or atrial fibrillation or atrial flutter of different etiology altogether. All right. So this is the classical multifocal atrial tachycardia. Here you see 3 different morphologies of P wave and a irregular QR complex and a rate more than 100. This is the diagnostic hallmark. So you must look at these P waves. Always look at the P wave. You see when there's upright, the same rhythm, you have an upright P wave, a biphasic P wave, and you have a downright P wave. So it's very important to make out multifocal atrial tachycardia because multifocal atrial tachycardia is very common in patients with COPDs. Atrial flutter, just for completion, atrial flutter when the atrial discharge or the SA node discharge rate or depolarization is between 200 and 440, you see this short tooth pattern, the smooth pattern of P wave. Now it's very again important to and differentiate atrial flutter with atrial fibrillation, because sometimes you may have atrial flutter and atrial fibrillation at the same time. You may have multifocal tachycardia. Though the treatment part may not make much difference, people will say, "यार क्या करना है?" Just it is an atrial arrhythmia, but it is important to know the detail because sometimes the devil lies in the detail. So this is the classical picture what you see in the atrial flutter. Normally the RR interval may appear to be normal in atrial flutter, and generally it's called 3:1 block or 3:2 block. This is what we see the 3:2 conduction, apart from saying block. Block is a wrong terminology here. Then going back to atrial fibrillation, we have the sawtooth pattern. The atria is discharging at a very high rate, around 300 to 500. Where the whole the whole of atria, apart from the SA node, has become the focus, and the rhythm are coming from all apart from the atria. And you see this fibrillatory wave or the S wave, we call this the atrial fibrillation. Most of us who have worked in cardiology for a long time may not find difficulty in understanding atrial flutter and atrial fibrillation and MAT, but younger physicians, people those who are just looking at the ECGs, tend to make these small mistakes, and these mistakes do matter because if you start a patient on anticoagulant who has MAT, then this changes the whole therapy game. All right, so I think this is very clearly shown here. Understanding atrial fibrillation is very important because the RR interval is again different, and you can see there's no the P wave. There appears to be a normal P wave, and the second there is actually virtually no P wave. So if you do not look clearly, you will not find those fibrillatory P waves which is lying on the all across the PR segment or all across this segment. So these are all P waves here. These are all P waves. These are all P waves across this whole domain 2 QRS complex. All right. Sometimes you will find a normal P wave and you will find a wandering pacemaker. Wandering pacemaker is actually nothing. Sometimes you will have ectopic focus where the SA nodes start discharging, or there is some focus that is just below the SA node where the discharge or rhythm will occur, and they become the wandering pacemaker. Generally, the PR interval there is very short, and they are very near to the QRS complex. So this is see the first P wave in QRS complex. Second, look at the third and the fourth QRS complex. In the fourth QRS complex, the P wave morphology is different, and the PR interval is quite short here. This is a case of wandering pacemaker, wandering atrial pacemaker. Sometimes the P wave or small P wave is buried inside the QRS complex. Sometimes you will not find these long pauses, especially when you're dealing with end disease patients, and we tend to confuse them with complete heart blocks or put them pacemaker. There's nothing but complete sinus pause. You see there's a normal P wave and there's a pause here. There's no P wave and not discharge yet, and took a long time for the next discharge to occur. If there was a complete heart block, there would have been a P wave discharge here. All right. So it's very important for us to make a differentiation between a sinus pause or a complete heart block. So you need to know your P waves very well. So with this, I like to end my presentation. I know it was a very basic presentation. I tried to make it very simple, and I hope I have answered all the questions. Thank you very much.
Thank you, Nishant sir. It was a beautiful presentation, and you have covered most of the topics of P wave. I would also like to bring the notice on short PR interval syndromes like WBK2 syndrome, LNL syndrome. So
I did not put those because I thought we are dealing about P waves. So I thought I'll just leave it the PR.
So actually, P wave is such a big topic.
Right.
No, it was beautifully explored, and it is such a big topic that the multiple lectures can be taken on P wave with the short PR intervals, then AV blocks, then SA blocks and all.
So, I did not go on tachyarrhythmias and PR interval, because then I thought it will become too deep and it become too for anybody to understand.
But
so
it is very important, as you rightly said, that P wave is very important to see, because most of the technicians make this mistake of if they don't check AVR, then the whole ECG is upside down.
P wave is upside down, correct.
Right. Thank you, sir. Thank you.
निशांत,
Thank
ये
you.
भी टॉपिक हो सकता
Yes,
है,
sir.
मुझे आज समझ में आ रहा है।
हाँ सर, ये एक
बात
बहुत अच्छा
मान
टॉपिक
करके
है।
आई गेस आउट ऑफ द
I think you
बॉक्स
will
टॉपिक था।
remember, sir, I think you will remember
वंडरफुल
Deepak sir
प्रेजेंटेशन। ठीक
saying
है,
that
टाइम थोड़ा ज्यादा लगा हम
I,
लोगों को, लेकिन वंडरफुल प्रेजेंटेशन। अपलॉड्स टू
I
यू।
remember, sir, once Deepak, yeah, thank you, sir. I remember once Deepak sir told me ki you mind your P's when you're reading your ECG. He
Any other
said, mind
comments,
your
any questions
P's.
for Dr. Nishant?
Yeah. Hmm.
In that case,
Really very nice presentation, sir.
in that case, we
Thank you
move
very
to
much.
the next topic. And before that, I would like to request our speaker to kindly accept the certificate, and also to our chairpersons,
Thank you,
Dr. Hiren Mehta, Dr. Alka ma'am, Dr. Rupam, Dr. Manish. Thank you so much.
Sorry to
Next,
interrupt
we
you,
have
sir.
President.
Dr. Vineet, sir, sorry to interrupt you, sir. Nishant, sir, you need to stop sharing your screen because.
Yeah, sure,
Yeah,
sure, sure.
yeah. Okay,
One
thank
minute.
you.
Yeah.
Okay. So now this screen is visible, Hemaki.
Yes, sir. Yes, sir. Your screen is
Fine.
visible now.
Kindly accept the certificate of Nishant, Dr. Hiren for chairing the session, Alka ma'am,
Thank
Dr.
you, sir.
Rupam,
Thank
and
you
Dr.
very much.
Manish. Thank you
Thank you
so
very much, sir.
much.
Thank you very much,
Thank you,
sir.
sir. Thank you.
Thank you very much, sir. Thank you, sir.
Thank you, sir.
Next, we have presidential oration, and for that, we have Dr. Pragnesh Shah with us. And first of all, I would like to thank Dr. Pragnesh, both Dr. Pragnesh Shah and Dr. Vachharajani, for giving FPA Ranchi this opportunity to host this webcon on ECG. To share the session, we have Dr. Janak Shah. He is right now not here due to some issues. And then we have Dr. YGK Reddy, Dr. Uday Shankar, and Dr. Arun More from Barshi, who is clinical cardiologist, teacher, speaker with publications, trials, peer-reviewed papers, co-editor and reviewer of journals, and member of various organizations. So I request Dr. Pragnesh Shah to kindly take over from here, and our chairpersons. And before that, kindly accept this memento, certificate, and medallion for presidential oration.
Thank you, Dr. Vinod.
Over to our chairpersons, Dr. YJK Reddy, Dr. Uday, Dr. Arun, any?
Hello, guys. This is Dr. Arun.
Yeah, Dr. Arun.
Hello, Dr. Vinod.
Yeah, session is from Dr. Pragnesh Shah.
Yes. I think it's quite a very good opportunity. ECG being the most basic thing, and I personally believe. I mean, ECG is, though it is discovered 100 years ago, still it is very much underutilized, underused in the society by everyone. I mean, the patients or doctors. And basically, the doctors, any faculty doctors, MBBS, non-MBBS, or any medical professional, it's very important to let them know what ECG is, and the basic things. Exactly as Dr. Nishant's session gave us so beautiful ideas about knowledge about from the P waves. I'm sure Dr. Pragnesh Shah, we'll be having this very useful session of ECG and arrhythmias. Dr. Pragnesh Shah is from Vadodara, and he's one of the very eminent, actually, member of our Physiology faculties. And I request him to go ahead with this. In the last couple of years, I have found that many doctors identify on VTVF, and we lose the patients in front of our eyes. So arrhythmia is very important of our ECG for identification and management. I request Dr. Pragnesh Shah to go ahead and present this topic.
Thank you, Dr. Arun, and all the chairpersons for a kind introductions. Thank you, Dr. Nishant. You did my job very easy. As we all know that this is the normal electrical conduction system of our heart, and
Dr. Pragnesh, sir, Sorry
Yes.
to interrupt you, sir. Sir, could you please change your slides into full screen mode, sir?
Yeah, it is in the full screen on my screen.
But we can not see it in the full screen mode, sir.
Let me stop sharing, and I would like to share it again.
We can see your screen, sir, but it's not in full screen mode, sir. Your slides are with me, sir. If you want, I can share it from my end, sir.
Please
Okay.
share from your
Sure,
side.
sir.
Yeah.
Just give me a moment, sir.
Yes.
चलो तो और क्या हो गया
See, in spite of we are reaching to the moon, we still have such technical glitch. Oh, thank you. Thank you, Sarini, for sharing the screen. Can you move to the...
Yes, sir. Is my screen visible to you?
Yeah, it's visible to me.
Is it in full mode, sir?
No, it is not in full mode. Can you move to slide number 4 directly?
It's, I think, in PDF kind of mode. It's not in PPT mode.
And it is PPT, but I don't know how this.
Is it fine, sir?
No, it is not in the full screen mode.
Okay. But I was sharing in the full screen mode, sir.
But it's okay if everybody is seeing, then I don't mind to read their slide also.
Okay.
Share it and change the slides.
Okay, sir. I'm sharing.
See, basically the arrhythmia and ECG to cover within the 20 minutes is I think we can.
Is it fine, sir?
Yeah, yes. Is it? Yes, it is
Fine.
fine.
This one is the best.
This is the best.
This is the most important slide of whole CME.
Next.
We should.
Next slide, please. Yeah. As it is very difficult to cover the ECG and arrhythmia in 20 minutes, but I will try to justify the subject and I will talk for 20 to 30 seconds for each the arrhythmia and give the spot diagnostic tips on that ECG. First of all, I would like to thank Dr. Nishant that he made my job so easy that for detecting any arrhythmia on ECG, P wave is very important. This is a clear-cut message from Nishant. So next slide, please. We also know this the normal conduction, impulse conduction system of the heart. That from the SA node is the pacemaker of the heart, and from the SA node, electrical pulse will enter in the AV node, then through the bundle of His to the bundle of branch and the Purkinje fibers. This is the normal impulse conduction in our heart. Next slide, please. So these slides give you some insight where to see for the arrhythmias. So there are two types of the basic two types of the reason that arrhythmia will generate, and one is when the time of the formation, and second is at the time of the conduction. So we have to see that the origin of the impulse is from where? SA node, atrial, or AV node, or the ventricle. So we have to see what is the pacemaker of that rhythm. Then we have to see the rate. It is normal, brady, or tachy. Then we have to see the regularity of the rhythm. Is it regular or irregular? And then we have to see the onset. It is passive escape or the active escape. Next slide, please. So at the same time, we must have a knowledge that SA node is a dominant pacemaker of the heart with the interesting rate of the 60 to 100 per minute. AV node is a backup pacemaker of the heart with the intrinsic rate of the 40 to 60 per minute, and ventricular cell have a backup pacemaker with the intrinsic rate of the 20 to 40 per minute. Next. So for that, to detect the arrhythmia, we should know the normal sinus rhythm. As discussed earlier, each P wave is followed by QRS complex. Then the P wave is having normal morphology, and the QRS complex is narrow, and the rhythm is the regular. This is the normal sinus rhythm. Next. So this is the normal sinus rhythm. Rate is between 60 to 100. Next. Only thing is physiologically normal is the sinus arrhythmia. It is a basically respiratory sinus arrhythmia is a physiological finding in the healthy young adult when the rate of the sinus pacemaker is relatively slow at the beginning of the expiration, and it will increase during the inspiration. So you can very well see that each P wave is followed by QRS complex, but the rate is varies. So, and the PR interval is also same. So it is a normal sinus arrhythmia is a normal physiological condition. Next. Now, how to think about arrhythmia and conduction disturbances. So now we all know about what is a sinus rhythm or what is a normal ECG. As I told earlier, that rhythm is regular, heart rate is between 60 to 100, P wave is the normal, morphology is followed by QRS complex, and P wave is positive in lead 2, 1 and inverted in AVR. So any ECG trace that does not fit with this criteria of the sinus rhythm is considered as an arrhythmia. Next. So this is already discussed. Next. So for the arrhythmia, now we know, I assume that you all know how to calculate the rate. So if the heart rate is less than 80, less than 60, it is Brady arrhythmia, and if heart rate is more than 100, it is the tachyarrhythmia. So first we will discuss about the tachyarrhythmia. So we will divide the tachyarrhythmia for the easy learning purpose in two categories: narrow complex tachycardia and the broad complex tachycardia. Next, please. As if the QRS complex is less than 120 millisecond, it is a narrow complex, and more than 120, it is a broad QRS complex. Next, please. Yes. So as Nishant is very rightly says that P wave is important. So first we have to see that rhythm is regular or irregular. If there is irregular rhythm, there are only 3 narrow complex tachycardia with irregular rhythm. You have to remember only three possibilities. One is atrial fibrillation. Second is atrial flutter with variable AV conduction. And third is multifocal atrial tachycardia. Next, please. Okay. So now we are discussing of the regular narrow complex regular tachycardia. So it is a sinus tachycardia. Second is junctional tachycardia, atrial tachycardia, and atrial flutter with fixed AV conduction, and SVT, supraventricular tachycardia. And in the wide broad complex tachycardia, if regular, it is ventricular tachycardia, and if irregular, it is polymorphic ventricular tachycardia or the torsades pontis. And there is one condition with the SVT with the aberrancy. It will also give both the regular and irregular blood complex tachycardia. Next, please. So this is again the same, but very beautifully described about the tachycardia. Next, please. So at the family physicians level, we are going to discuss the 4 major narrow complex tachycardia. Sinus tachycardia, we all know. Then SVTs, supraventricular tachycardia, atrial flutter, and atrial fibrillation. Next slide, please. Next, please. Okay, sinus tachycardia. So the sinus tachycardia, the clue is rate is more than 100. Rhythm is regular. RR interval is regular. Each P wave is followed by QRS complex. QRS complex is narrow. This is the sinus tachycardia. Next. Now, if you find that it is narrow complex tachycardia, but the rhythm is irregular and P wave is not visible, it is atrial fibrillation. Here you can see in the inset that the green line says the expected QRS complex after the P wave, but it is not there. And you can also see that rhythm is irregular. Narrow complex tachycardia with irregular rhythm, it is atrial fibrillation. Next, please. This is the very simple thing to remember, that narrow complex tachycardia with absent P wave and regular rhythm, it is supraventricular tachycardia. Then there is a long algorithm which shows that it is AVRT, AVNRT, it is typical AVNRT or atypical AVNRT. We are not going to detail in that in that classification, but remember one thing, that it is the narrow complex tachycardia, absent P wave, and rate is regular. It is supraventricular tachycardia. Next, please. And if there is supraventricular tachycardia, and if you do any vagal maneuver or adenosine, if you do the carotid massage after seeing there is no carotid brood, you can convert the supraventricular tachycardia in the normal sinus rhythm. Next, please. Yes, atrial flutter. The atrial flutter, you may find regular rhythm or irregular rhythm. In the first ECG, left side upward, you can see it is irregular rhythm, and the below you can find the regular rhythm. Atrial flutter, the main ECG characteristic, the atrial rate is typically between 240 to 400 per minute. There may be a irregularities is due to the AV conduction block. If the AV conduction blocks are fixed, then there is a regular atrial flutter. You can say the regular rhythm, you can see. And if there is a variable conduction block, you can see the irregular rhythm. So that AV block may be 2:1 or 3:1 or 5:1. And you can very well identify the sawtooth appearance. The sawtooth appearance is the main features of the ECG on the atrial flutter. Next, please. Yes, if this is the Jagsonal rhythm, if you are not able to see the P wave on the ECG, or you can see the P wave, inverted P wave, or P wave is merged in the QRS complex, or if the after QRS complex, it is the Jagsonal rhythm. If the heart rate is between 40 to 60, it is the Jagsonal rhythm, and it is regular. Next, please. If the rate is more than 100 and rhythm is regular, but you are not able to find the P wave, if P wave is inverted and P wave is after the QRS complex, it is the junctional tachycardia or the atrial tachycardia. Next, please. Next, please. We will now discuss about the bradyarrhythmia. So mainly you have to look for the 3 main bradyarrhythmia. One is sinus bradycardia, second is sinus node dysfunction, and third is the AV blocks. Next, please. As we discussed in the sinus tachycardia, same thing with the sinus bradycardia. It is the heart rate is less than 60. Each P wave is conducted by the QRS complex, normal PR interval, and rate is regular. Rhythm is regular. Next, please. Sinus arrest. If the SA node fails to generate an impulse at all, it is called the sinus arrest. If more than 2 complete PQRST is dropped, it is sinus arrest. If this pause is less than 3 seconds, it is sinus pause. And if the pause is more than 3 seconds, it is a sinus arrest. It means the 5 large box consists of 1 second. So if there is more than 15 big box on the ECG, if you are not able to see the next complex till 15 large box, is the sinus arrest. And if you can not able to see the next QRS complex after 7 to 8 big box, it is a sinus pause. Next, please. This is the same thing. You can see. You can also see here the SA node is not generated at the 1 or 2 axis, and it's more than 3 seconds in the connective rhythm strip. The pause is increasing for the 4 seconds. So it is a sinoatrial block. Next, please. Now we will discuss about the AV node block or AV node conduction block. So there is good newly married couple or the couple algorithm or story for this AV node block. I hope you all know about it. In the first degree AV node, the PR complex is increasing only. All other things are okay. The P wave is, each P wave is followed by QRS complex, but the PR interval is more than 0.2 seconds. So it is called as the first degree AV block. So let me tell you the couple algorithm story of this AV block. Once there is a married couple and the husband is working and wife is housewife. So husband is used to come after marriage 5 o'clock at the evening at the home. So this is the normal PR interval. The husband went to office at the 9 a.m. and come back at the 5 p.m. So the PR is normal. So this is the normal sinus rhythm. After 6 months or 1 year or 2 years of the married life, the husband used to come at the 5:30 p.m. or 6 p.m. But it's regular. Now he a little bit late from the office at the 6 p.m. daily, but he comes regularly at home. So the PR interval is increasing. So it is the first degree AV block. Next, please. In the second degree Mobis type 1 AV block, that PR interval is progressively increasing, and suddenly it's failed to convert it into QRS complex. It means that husband is come to home instead of 6:30 p.m., 7 p.m., 9 p.m., but he comes to home. But suddenly on one day, he fails to come home. So this is the second degree AV block with Mobis type 1. Next, please. This is the second degree AV blocks with Mobis type 2. In this, the PR interval is prolonged but constant. But suddenly, periodically, the PV is not followed by the QRS complex. So the husband is used to come late, but at the regular time, but suddenly he fails to come home. So the PR interval is consistent, but periodically the P wave is not followed by the QRS complex. This is the second degree AV block. Next slide, please. Now, this is the third degree AV block. you can see that each P wave is not followed by the QRS. There is complete uncoupling of the atrial and ventricular rhythm. So the P to P interval will be much shorter than the RR interval. This is because the SA node has a higher level of atomicity compared to the Purkinje fiber or the ventricular mass. So, but the RR interval is typically constant. Here, the husband fails to come for 2-3 days, or he come at his pace, wife come to home at her pace. Next, please. So now we will discuss something about the broad complex tachycardia. Next slide. In the broad complex tachycardia, we are considering two possibilities. One is regular broad complex tachycardia and second is irregular. Next, please. If regular broad complex tachycardia, unless proved otherwise, it is treated and considered it a ventricular tachycardia. There is second possibility is SVT with aberrancy. It will also give you broad complex tachycardia with regular rhythm, but it is, unless proved otherwise, consider any broad complex tachycardia as a ventricular tachycardia if rhythm is regular. Next, please. So regular rhythm, absence of P wave and broad complex, there is no second head, it is a ventricular tachycardia. Next, please. Yes, this is the polymorphic VT, or we can also say Torsades pontis broad complex tachycardia with irregular rhythm, bizarre rhythm. It is a Torsades pontis. It is the medical emergency. All the broad complex tachycardia, consider it is a medical emergency. Next. A ventricular fibrillation, the rhythm is chaotic, rate is chaotic. Ventricular fibrillation is lethal with no cardiac output, and defibrillate immediately with an initial unsynchronized dose of 360 joules monophasic. And if you are a patient in hospital, or if your injection epinephrine or adrenaline, give the shot of the adrenaline every 3 to 5 minutes. Next. Now, Dr. Nishant is already covered the atrial ectopics. So the first visit to the atrial ectopics. Next slide, please. There is a first P wave, which is the second P days come earlier to its normal time. So it is the atrial premature beat. Next, please. Next slide. This is also an atrial premature beat. You can see the third beat is the premature atrial contraction. Next, please. Next, please. It is repetition. Sorry for that. Next, please. If this atrial premature beat is coming on regular interval, it means if every second beat is atrial premature beat, it's also called atrial bigeminy. Next, please. We all know about this. Dr. Nishant already told that if P wave is inverted, it is originating from other than the SA node, so it is a ectopic atrial rhythm. Next, please. Dr. Nishant also, if there is more than 3 different P wave, it is the wandering atrial pacemaker. Next, please. If there are more than 3 morphological P wave with the rate more than 100, it's a multifocal atrial tachycardia. Next, please. About the preventricular contraction occurs earlier than the QRS complex, occur earlier than the expected time, and it is wide QRS and no P wave. It is considered it is a premature ventricular contraction. Next. If no P wave, it means it is a junctional rhythm, broad QRS complex, consider it is a idioventricular rhythm if the rate is between 20 to 40. Next, please. And if the rate is between 40 to 100, consider is a accelerated idioventricular rhythm. Next, please. Wishing you all very happy ECG learning. Thank you. Thank you very much.
Thank you so much, Dr. Pragnesh. Any questions for Dr. Pragnesh? Over to chairpersons.
See, I know it is very difficult to cover all the arrhythmias in 20 minutes, but I tried to cover all the silent feature of the commonly occurring arrhythmia and say the fine points about them.
Yeah, I think Dr. Pragnesh, thank you for such a, very brief but very important and basic introduction to the arrhythmias, and it was quite, very good information what you given from your lecture. I from personally, when we are into practice, we find, we have a lot of arrhythmias. It's maybe brady, it may be tachyarrhythmias. But what we see is that the VT, VF, AF, flutter, SVT these are very common, arrhythmias which needs to be identified by the doctors. And especially when we practice as a cardiology, yes, all the arrhythmias we have to know. But Dr. Pragnesh, can you just brief our, non-physician doctors how to pick up this? Differentiate between, or is there any clinical differentiate when we are differentiating between SVT and this VT for in general doctors, non-physician doctors? They generally get confused over there.
SVT and VT. If there is the narrow complex tachycardia, regular rhythm and absent P wave, it is SVT. If it is broad complex tachycardia and absent P wave and regular rhythm, it is a ventricular tachycardia. This is
Exactly.
the simple message for the family physicians to differentiate between SVT and the ventricular tachycardia.
Exactly. So the broad complex, the broad or narrow complex of the QRS that differentiates from the supraventricular and ventricular tachycardias. Yeah, I think this is quite very useful information. What it should be passed on to the family physicians and Dr. Vinith. I think basically this arrhythmia, session should be much more in future too. I found this particular today's web session very good. And thank you, Dr. Pragnesh. If anyone has any questions for him, please go ahead.
Dr. Reddy, your comments, please.
Reddy sir.
Hello.
Oh, Reddy sir.
So there's a nice presentation. Which question pushna hai nahi? All well presented.
Thank you so much. चाकीदा, आपके लिए कुछ कहना है?
अरे वाह रेड्डी साहब.
फिलहाल कुछ नहीं. I'm just enjoying the excellent presentations by our esteemed speakers.
Thank you so much, but somehow your speaker is absent, Chakida. I'm sorry.
No problem.
That lecture has to be cancelled. So I request Dr. Pragnesh to kindly accept his memento, certificate and medallion. Also, thanking our chairpersons, Shah sir, Dr. Reddy, Dr. Arun More and Dr. Uday Shankar to kindly accept the certificate. I request Dr. Sunil Sinha and Dr. Kaushik Chaki, Dr. Abhay sir, Dr. Anil sir to kindly stay here for the next session. I'm very sorry this lecture has been cancelled due to some medical emergency which has come up with Dr. Deepak Gupta sir. So we move on to the next topic, which will be on ECG changes in valves. And for that we have chairperson Dr. Rikul Shah, Dr. Pankaj Kumar, Dr. Prerna Chetri, clinical cardiologist, and Dr. Deepak Jain, clinical cardiologist from Jamshedpur, Tardong and Delhi respectively. So Dr. Rikul Shah is a physician and medical officer at ESIS and secretary and vice president to FPA. So over to our chairpersons.
Good afternoon all. Our next speaker is Dr. Jagnany, sir. He is a consultant physician and cardiologist and diabetologist based at Ranchi. He is a fellow of FPECGCON, founder president of ISCC Jharkhand, and executive member of Jharkhand RSSDI. Over to you, Jagnany, sir.
Thank you so much. So I will be presenting ECG changes in valvular heart disease. We would like to cover this topic under the following headings. To begin with, we all know that heart has 4 valves: the mitral, aortic, tricuspid, and pulmonary. Stenosis is something when the valves do not open properly, and regurgitation is something when valves do not close properly. In stenosis, the orifice becomes narrow and restricts the blood flow. In regurgitation, there is a backward flow of the blood, and in prolapse, the valve slips into the atrium and do not close properly. So 2 things are happening. One, the blood is leaking back into the atrium, and the flaps of the leaflets are not closing properly and slipping into the atrium. So the diagnosis of valvular heart disease becomes quite a problematic thing in clinical practice, and therefore there is very importance of history and examination along with investigations like chest X-ray, ECG, echo. So today we will be focusing on ECG. To begin with, we have tricuspid stenosis, where we see tall and wide P waves in 2, 3, and AVF, which denotes increase in right atrium size, and the right ventricular hypertrophy is evident from tall R waves in V1 and V2. As there is tricuspid stenosis, the blood does not flow from right atrium to right ventricles, so the primary feature becomes the increase in the size of right atrium. I'm going to be very short and very specific, next being pulmonary valve stenosis. So what is going to happen here? The blood will not flow out of the right ventricle, so the primary feature will be seen into the right ventricle. There will be right axis deviation with P pulmonale, right ventricular hypertrophy, and right bundle branch block, which will be evident from tall R waves up to 50 millimeters in height and amplitude in V1, with deep inverted T waves in anterior chest leads. Along with that, there can be increase in right atrial size, which will be evident from tall P waves of more than 2.5 millimeter height, which are pointed in 2 and V1. And of course, thanking Dr. Nishant and Dr. Pragnesh for making my talk easier. Coming to the next one, mitral stenosis, which is mostly due to rheumatic fever. There can be other causes also. Now, in mitral stenosis, what is happening? The orifice of bicuspid valve, that is mitral valve, is narrow, so the primary feature will be seen in left atrial enlargement. The LA pressures will increase, and this will be evident by increasing the width of P waves, which will be more than 120 milliseconds in duration. There can be AF, the P mitral, and back pressure can cause right ventricular hypertrophy and right atrial right axis deviation. That will be a distant feature of mitral stenosis. So the strain pattern might be seen when there is in aortic stenosis. There will be left ventricular hypertrophy with a strain. Why? Because in aortic stenosis, the blood is not flowing out of the left ventricle, so the load is onto the left ventricle. So there will be hypertrophy of the left ventricle primarily, which will be featured by left axis deviation with left anterior hemi block and left bundle branch block, evident from tall R waves in V6, T inversion in V6, deep S in V1, and incomplete LBBB, which is evident with disappearance of Q waves, as is evident in this particular ECG. What we see here? We see here tall R in V6 with T inversion, quite clear, and deep S in V1 with incomplete LBBB with disappearance of Q waves. So this is aortic valve stenosis. Coming to the valvular prolapse, that is mitral valve prolapse, which will be evident from mid-systolic click on clinical examination. Here the valves do not close smoothly and they prolapse upward into the left atrium. This is evident from STT depression with T inversion in inferior leads. Now, this is also correlating with the inferior wall ischemia. So, it should be considered specifically in female with normal coronaries. If you are seeing this feature of STT depression with T inversion in inferior leads, we should think of mitral valve prolapse, as is evident from this particular ECG. We are seeing STT depression with T inversion. Coming to the regurgitation, so tricuspid regurgitation, here the valve blood will leak into the right atrium. So there will be black flow of the blood from right ventricle into the right atrium during systole. This will be evident by increase in the size of right atrium, and there will be right hypertrophy, which is evident from small Q valves and tall R in V1, which is due to the secondary to the pulmonary hypertension. This is a reflection of right ventricular hypertrophy and large P waves in 2-3 AVF, which is feature of increase in RA size. Pulmonary regurgitation, where the blood will flow back into the right ventricle. So this is another condition, and more so is with dilatation of the pulmonary artery and pulmonary hypertension. Atrial arrhythmia may be present. Isolated PR will show QRLS prolongation with RSR morphology with large R waves and small large S and small R waves, which is reflection of volume overload of right ventricle. There will also be right bundle branch block. So RSR morphology we are seeing with small r, deep S, and QRS increases, which increases further as the disease progresses, and this can lead to sudden cardiac death if arrhythmia precipitates. Now mitral regurgitation, where the blood flows back into the left atrium from the left ventricle. Here there is volume overload of left atrium, and therefore we will see increase in the size of left atrium. And since the left ventricle has to work harder, there will be left ventricular hypertrophy, which is once again evident with wide P waves, and which will be more than 110 milliseconds. It can be bifid in 1-3 AVL and lateral leads, and hypertrophy will be evident with tall R and T waves in lateral leads V5, V6, as is evident here. Now aortic regurgitation, here the blood flows back into the left ventricle from the aorta. So we will have left axis deviation, left ventricular hypertrophy evident from deep S waves in V1 and V2 with tall R in 1 AVL and V5, V6. So lateral leads will show tall R waves and deep S in V1, V2. And if we add these two, the height will be up to 70 millimeters, and total QRS also increases up to 350 millimeters. This is also added with left ventricular volume overload, which is evident from Q waves in 1 AVL and lateral leads V3 to V6. If there is strain along with aortic regurgitation, we can also see ST depression and diffuse ST depression with T inversion. So to conclude, valvular heart disease can be suspected with murmurs, signs, and symptoms. It could be incidental findings. We should go for to begin with non-invasive tests, which includes chest X-ray and ECG. Echo can be confirmatory. History and physical examination is equally important. I have not talked about murmurs, signs, symptoms. I have limited myself to ECG. We can take that some other time in detail when we talk. So here I conclude my talk. Any questions are most welcome.
Thank you, Dr. Jagnany. It's very informative, very short and very sweet, to the point presentation. It's wonderful, sir.
Thank you. Thank you so much, sir. Any other questions? Dr. Deepak is here. Dr. Prerna is here.
Thank you, sir. Thank you.
Dr. Kaushik Chakida.
Wonderful insight, sir. Thank you so much.
Thank you so much. I have been very short, restricting myself only to ECG, no science, nothing doing.
Thank you,
Dr. Jagnany sir.
Yeah.
Many of your ECGs were reminding me of posterior wall infarction, LVH with strain pattern.
Exactly. We need to differentiate that Shamroth very clearly says that we may confuse seeing this ECG with these infarcts. So we have to take history very meticulously, and we need to correlate with other investigations, enzymes. So that's very rightly pointed out, Sarji.
Dr. Jagnany, important point. Nothing can replace a good stethoscope. Auscultation.
Definitely. I fully agree. And if anybody has doubt, go for echo in case of, specifically in case of valvular disorders.
Dr. Jagnany, you have explained very nicely. All the ECGs were very simple to be interpreted, especially in the light of your concept. Thank you.
Thank you so
Beautiful,
much.
sir. Congratulations. Thank you.
So moving to the next topic. So this is, I would like to request Dr. Rikul Shah, Dr. Deepak Jain, Dr. Pankaj and Dr. Prerna to kindly accept the certificate, and also to Chakida, Dr. Sunil, Dr. Anil and Dr. Abhay sir. Thank you so much. We move to the next topic, which is by Dr. E.K. Singh. To chair the session, we have Dr. Ramlal Leela sir. He is graduate from Bombay and member of CPS from Bombay, past president of FPA Calcutta, Rotary Club, Udayan Club, IMA, New NW, vice president FFPI. He also organized conference of FFPI. He is executive member of Bharat Vikash Parishad Senior Citizen Forum and member of Bengal Rowing Club, Calcutta Punjab Club and Udayan Club. We also have Dr. Sagar Singh Solanki, Dr. Niranjan Sagar and Dr. Shanti Mala, clinical cardiologist from Daman, Motihari and Ranchi respectively. Dr. E.K. Singh will be delivering his talk as a speaker of the day. Kindly accept the certificate, memento and medallion. I request our chairperson, Dr. Ramlal sir, to kindly take from this point. Dr. E.K. Singh is a clinical cardiologist, MBBS, PG, DCC, and his special interest in intensive medicine in ICU. Over to Dr. E.K. Singh, sir.
Thank you, sir. Good evening to all. Am I audible? Hello.
Yes, sir.
You are yes, audible. Sir, you are audible.
Okay. Thank you. Good evening to all. Thank you for giving me opportunity to speak on this forum. Today I will be telling about ECG and chamber enlargement. Everything has been told in last 3 hours. All type of chamber enlargement. 50% was done by Dr. Nishant and 50% by Dr. Jagnany. I will be telling only about the physics of that changes. So there is a cardiac enlargement. We have 4 chambers, 2 atrium and 2 ventricle. First, I will be telling about atrium and then ventricle. So there is enlargement either because of dilatation or hypertrophy. Dilatation may because of a stressed chamber or as in congestive heart failure, or increase in size of muscles fiber like in aortic stenosis. If there is increase in amount or area of cardiac tissue, then the question arises, how did this affect depolarization? And how could that effect will be seen on the ECG? Now we will see the abnormality. If there is overlaid load on the right atrium, there is dilatation or hypertrophy, and this is also known as P pulmonale. It has been already told and discussed. How would this change the P wave? We can see here, there is tall P wave. This is the vector actually when the pulse starts from SA node, it goes to AV node and then ventricle. First it depolarizes the right atrium, then left atrium, and then ventricles. So a resultant vector will be on that left side, right side, sorry, and this is smaller vector towards the right side. Then when we will see the on the frontal leads, we can see in lead 2, lead 3, ABF or V1, but mainly on lead 2. This is normal ECG, normal P physiology, normal QRS, and normal T wave. So normal P wave is less than 2.5 mm tall and 0.12 second wide. We are seeing two things here: the tallness, amplitude of that wave, and the wideness of the wave. If there is right wave arterial hypertrophy, P wave are typically taller than 2.5 mm, but not wider than 0.12 second. Here is only one changes in amplitude of that P wave. Tall P wave in lead 2, we can see on lead 3, ABF, and sometimes V1 also. But mainly we will focus on lead 2. The causes is pulmonary disease, like already told, pulmonary hypertension or COPD or congenital heart disease. Now, the left atrial abnormality. Left atrial abnormality, normally known as P mitral. Left atrial abnormality depolarizes after the right atrium. Dr. Nishant had shown one graph. The first part is right atrium and second part is left atrium. How do this affect the P wave? Obviously, P wave become wider. So wider than more than 0.12 second, more than 3 small houses. Left atrial, if left atrial abnormality is there, resultant vector will be towards the left. Hence, on the left lead, we can see clearly lead 2, lead 1, lead 3, and ABF. Here we will see this lead 2, wide P wave, and in V1, there is negative P wave. The criteria for this is minimum 1 box wide and 1 box deep. Then lead 2, we will see and focus. We will see the wide P wave, second hump due to delayed depolarization of left atrium, and P mitral we see fail. Only it was initially recognized as mitral valve problem. V1 may show biphasic P wave, 1 box wide and 1 box deep, and biphasic because right atrium is anterior to left atrium. So here is we can see the biphasic P wave. So, to summarize, if we will see right atrial hypertrophy, lead 2, it will be taller, and V1 also it will be taller, but left atrium, it will be like M, wide, and biphasic in lead V1. The causes is normally valve disease, like mitral or aortic valve disease, hypertensive heart disease, cardiomyopathy, or coronary artery disease. In all, we get left atrial abnormality. Now we will go to ventricular hypertrophy. We have 12 leads, 6 is frontal leads, and 6 is transverse lead. Initially, in atrium, we were focusing on the frontal lead. Now we will focus on transverse lead to see the ventricular enlargement. This is normal QRS complex in V1, and when we will see here, we will see the positive deflection initial in V1, in normally, and in V6, normally Q wave is small. So this is normal ECG, lead V1 and lead V6. Small r, deep S, small q, and tall r. What do you think will happen to the ECG with ventricular hypertrophy? This is normal ECG. If there is right ventricular hypertrophy, then we will see in V1. V1 will be different because initial R wave is smaller in normal ECG. But if there will be hypertrophy, R wave will become taller in V1 lead. Here, if you will see the physics, normal resultant vector. Excuse me, 1 minute. मैं कॉल करता हूँ सर 2 मिनट में. This will be the normal vector. If there will be right ventricular hypertrophy, vector will go towards the right. And if will be more hypertrophy, it will again more go to the right side. Then we will see more positive wave in V1 and less positive in V6. So deep S wave we will see in V6 and tall R wave we will see in V1 if there is right ventricular hypertrophy. So there is a criteria in V1, R wave greater than the S wave or R in V1 greater than 7 mm. Independent criteria, right axis deviation in V1, T wave inversion. Region is unknown, but if it is tall and T wave is inverted. S wave in V5 and V6. Causes of right ventricular hypertrophy is pulmonary disease like pulmonary hypertension or COPD or any obstructive disease, congenital heart disease. There is if masking of RBH sign in ECG if patient have emphysema. And posterior wall MI also show tall R wave in V1. And how to differentiate that in previous lecture we have seen. This is the ECG. R wave and T wave in V1. We can see here R wave, T is inverted, and axis is right axis deviation. If we will see here, 1 and 3, it is right axis deviation. This is normal if we are interpreting, already said, we will have to see the systematically rate rhythm. We are doing all, and we should go with this protocol only. We can see here R wave in V1, it is tall, and P wave in 2-3 lead to P wave is taller. So obviously there is T wave inversion in and PR interval is slightly more. Now left ventricular hypertrophy, when we will see for with LVH electrical balance is tipped even further to the left. Initial Q wave and smaller R wave, and now tall R wave in left side of the lead. All left side of lead, we will get taller R wave. Prominent wave, S wave in chest lead, right lead. Here, if you will see the vector, this is normal vector. When there is left arterial, left ventricular enlargement, it is going towards the left. And if more hypertrophy, and then it is again more going to the left. So obviously, left side lead, we will get more positive deflection, and right side lead, we will get more negative deflection. Now, criteria, there are too many criteria for this left ventricular hypertrophy, but easiest and easy to remember is Shockley-Lyon voltage criteria. If S wave in V1 plus R wave in V5 or V6 is more than 35 mm, and if it is more than 50 under 35 years of age, then we can say LVH. R wave independently more than 11 mm in AVL or 1. And also there is left ventricular hypertrophy more likely with strain pattern or ST segment changes. And left axis deviation. Left after arterial abnormality we will find, normally we find simultaneously. Causes of left ventricular hypertrophy is hypertension, aortic stenosis, and it is not always pathological. And risk of LVH is congestive heart failure and arrhythmia. The high voltage can be seen in the normal people also, especially athlete, and with hypertrophy in both the ventricle, the ECG will show more evidence of LVH. This is a strain pattern. This is left ventricular hypertrophy because R wave here in V6 and S wave in V1. It is more than 35. Left arterial enlargement is also there. When we will see the lead 2, this is more wider, and tall R wave, and this inverted T wave. LVH in 20 years old without ST pattern, left atrial enlargement is also suggestive. Lead through and B1. Now this is just to see, sorry, this is RBH pattern, tall R wave with T inverted. This is left atrial enlargement. If we will see P mitral, and in V1 we can see biphagic. This is left ventricular hypertrophy, R wave and deep S wave, more than 35 mm. This is left ventricular hypertrophy. We can see tall R wave here, and if we will add, it will be more than 35. This is right atrial enlargement. We can see that tall R wave, but it is not wider. This is LVH. This is right ventricular hypertrophy, tall R wave, more than S, and the right atrial enlargement, tall P wave. We can make out here. This is RVH, same tall R wave and inverted T wave. Now this is left ventricular hypertrophy with a strain pattern and left atrial enlargement by T. It should be 1 mm wide and 1 mm deep. This is left ventricular, right ventricular hypertrophy. Tall R wave, P wave, taller. And I am finished because everything was done. That is why I was mentioning only the physics part, not the physiological part. Any questions? Thank you.
Any comments, any question for Dr. A.K. Singh, sir? Dr. Pragnesh would like to say something. You are mute, Sirji.
Yes, it is really excellent presentation, Dr. Singh sir. It is very lucid and very well informative.
Thank you,
sir.
Thank you so much. Thank you, AK sir.
Thank you, sir.
So kindly accept the certificate.
Thank you, sir.
Also for our chairpersons, Dr. Ramlal sir, Dr. Sagar, Dr. Niranjan, and Dr. Shanti. Moving to the last session, we have Dr. Ravi Kachhela as a speaker. To chair the session, we have Dr. Aditya Jingran from Lucknow, Dr. Renuka Verma from Bokaro, Dr. Nishant Chaurasia from Devgar, and Dr. Indra Panda from Bhubaneswar, clinical cardiologist. Dr. Ravi Kachhela is a renowned interventional cardiologist at Ranchi at Ram Pyari Super Specialty Hospital. He is an ex-soldier being graduate from AFMC Pune, postgraduate from Army Hospital New Delhi, DNB Cardiology, gold medalist from Sri Satya Sai Institute of Higher Medical Sciences, Bangalore. Of course, he has served Navy and Army Hospital for 10 years. He is into cardiac care and structural heart disease. He will be talking for ECG in heart failure. He is here as a star speaker, and for that, I request him to kindly accept the medallion, certificate, and memento. With these few words, I request Dr. Ravi Kachhela to kindly take over. Our chairpersons are here. Dr. Indira, Dr. Renuka, Dr. Jingran. Over to chairpersons and speaker.
Thank you, sir. Thank you for your nice words. And Thank you for inviting me to this session, sir. I'll be speaking about ECG in heart failure. The ECG can give us a suspicion whether this patient is suspected to have heart failure or not. And ECG is not conclusive for proving heart failure. But yes, ECG can give us a very good suspicion, and we can go to the diagnosis of heart failure further evaluation. So heart failure per se is defined as a complex clinical syndrome in which there is inability of heart to maintain cardiac output, which is commensurate with body's metabolic needs, or its ability to do so at an elevated ventricular filling pressure. That is, it includes both heart failure with reduced ejection fraction. When we say on echo or other imaging, if we get LV ejection fraction of less than 40%, or heart failure with mid-range ejection fraction, when we get LV ejection fraction between 40 to 50%, and heart failure with preserved ejection fraction, when on echo or any other imaging, LV ejection fraction is more than 50%. We can also have heart failure with improved ejection fraction, in which the present LV ejection fraction of the patient is more than 40%, but it had documented previously that the LVEF was at some time less than 40%, and now after treatment, probably it has improved to more than 40%. So most of the causes of heart failure, I'll just on last slide on heart failure. Ischemic heart disease is the major cause, and valvular heart disease, hypertension, idiopathic dilated cardiomyopathy, hypertrophic cardiomyopathy, inflammatory cardiomyopathy, and infiltrative cardiomyopathies. So what we find in ECG will be based on the what has caused the heart failure, whether it is ischemic heart disease or valvular heart disease or hypertension or idiopathic DCM. What we will talk about initially will be only for the heart failure with reduced ejection fraction and mid-range ejection fraction, that too most of the cases representing idiopathic dilated cardiomyopathy. So ECG is abnormal in around 98% of patients with heart failure, and only rarely we find that ECG is normal, but the patient still has heart failure. So most common ECG finding in decreasing order of frequency is left ventricular hypertrophy, left atrial enlargement, poor R-wave progression in precordial leads, the QTC prolongation, left bundle branch block, low voltage complexes in the limb leads, and left axis deviation. We can also have evidence of old myocardial infarction in the ECG. So some of the definitions when we say ECG abnormal, the P wave duration more than 120 millisecond is counted as abnormal. PR interval more than 200 millisecond is abnormal. And for heart failure, the QRS duration is more than 100 millisecond is abnormal. Though we said wide QRS when it is above 120 millisecond, but generally the QRS is around 80 to 90 millisecond. So more than 100, we should start suspecting that there is some conduction abnormality or some heart failure setting in. Similarly, P wave axis between 0 to 75 is normal, and any deviation is called abnormal P wave axis. The QRS axis, left axis deviation beyond minus 90 degree to minus 30 degree to minus 90 degree is called left axis deviation. And if it is between minus 90 to plus 90, we call it right axis deviation. Prolonged QT interval is different for men and women. More than 450 millisecond is called as abnormal prolonged QT interval for men, and more than 460 millisecond abnormal for women. So in 1982, Berold and Goldberger described an ECG triad in heart failure with reduced ejection fraction. They said that the high precordial QRS voltage, that is what we call today as Sokolow-Lyon index, that S wave in V1 or V2 and combination of R wave in V5 or V6 more than 35 millimeter or more than 3.5 millivolt. So this is one of the findings of the triad. The second was relatively low limb lead voltage. At that time in 1982, they defined low voltage as less than 0.8 millivolt in each of the leads. The total deflection, R and S combined. In today's scenario, we call this low voltage complexes when it is less than 5 millimeter or less than 0.5 millivolt in limb leads. And last is poor precordial R wave progression. That means ratio of R wave to S wave less than 1 in the lead V4. So this is one of the ECG which satisfies Goldberger's triad. If we see, there is LVH by voltage criteria, that is the S wave in V1 or V2 in combination with R wave in V5 or V6 more than 35 millimeter in height. And second is sorry, low voltage complexes in the limb leads. If we see all the limb leads, it is less than 8 millimeter. Third is poor R wave absent in V1. There is a small R wave in V2, slightly higher R wave in V3, slightly higher, still higher R wave in V4, but still the ratio of R to S is less than 1 in V4. So this is called poor R wave progression if we do not find R becoming greater than S in V4. So at that time, Goldberger reported that they have this triad has 70% sensitivity, 98% specificity, and 100% positive predictive value for heart failure with reduced ejection fraction. That means if you come across an ECG which says LVH, but there is poor R wave progression and there is low voltage in limb leads, we should, according to Goldberger, we are 98% sure that this is a heart failure with reduced ejection fraction. But many subsequent studies reported that sensitivity is not that high, specificity is also not that high. So currently, this triad is not recommended for diagnosis, but for suspicions of dilated cardiomyopathy. So we can also have findings of old MI on ECG when we can suspect that this patient might be having a heart failure. Old MI can represent in the form of abnormal Q waves in more than one contiguous leads, or presence of left bundle branch block, and it can present as coved ST segment with T inversion. It can present as fragmented QRS. So this is one of the ECG which is showing, if you see carefully, which is showing two findings suggestive of old MI. One is Q wave in more than one contiguous lead. That is, there is a Q wave in lead 2, a large Q wave in lead 3, and again a small Q wave in lead AVF. So contiguous leads, by contiguous leads, we means that leads which represents a particular area of the myocardium. So lead 2-3 AVF represents the inferior wall of myocardium. Similarly, if we find Q waves in 1 and AVL, we can say it is a lateral wall MI. And if we find Q waves in precordial leads, we can say it's an anterior wall MI. So here there is a Q wave in more than one contiguous leads in inferior leads. So this ECG suggests inferior wall, old inferior wall MI. Also, if you look at carefully, there is a fragmented QRS in the inferior leads. The QRS, by fragmented QRS, we mean that if you look at precordial QRS in this particular ECG, like lead 2 has sharp R wave, sharp S wave. There is no fragmentation of this upstroke and downstroke. But if you see in lead 2, there is a fragmentation. Lead 3 also has a fragmentation of QRS. There is spiking of QRS in lead AVF as well. So both the findings, fragmented QRS and abnormal Q waves, are seen here. So this is one more ECG which shows abnormal Q waves in V1 to V4. V3. There is a very small R wave in V3, but it is mostly QS in V1, QS in V2, very small, and large S in V3. So this suggests old entry of MI. Also, there is an additional finding here which says this particular ST segment in the lead V2 and V3 is called coved ST segment. So this is coving of ST segment also represents old myocardial infarction. LBBB, for the unversed, LBBB represents as a left frontal branch block, represents as a very small R and large and broad S wave in lead V1, and large and broad R wave in lead V6, followed by subsequent ST depression and T inversion. And lead V1 we may find ST elevation and T upright. So this pattern is consistent with left frontal branch, negligible R and large and broad S wave. Broad means more than 120 millisecond. And again, large and broad R wave in V6. So this ECG satisfies the criteria for a left frontal branch block. This can also be a feature of old myocardial infarction, or it can also be a feature of de novo LBBB representing dilated cardiomyopathy. All these ECG findings give us a suspicion that the patient might be having a heart failure. They may not be in heart failure only based on ECG, and this could be just a conduction abnormality only. Ventricular premature complexes also represents diseased myocardium. Is if there is a ventricular bigeminy. By bigeminy, we mean that by another ventricular premature complex, that is which is a broad complex. So if you see the long lead, one normal, one VPC, one normal, one VPC, this pattern is called bigeminy, ventricular bigeminy. So this pattern is particularly ominous and could be a sign of QT prolongation. Is a very important feature of diseased myocardium. By QT segment, we mean that the interval starting from Q wave onset till the end of T wave. So normally there are various ways to calculate QT interval. QT has to be corrected for heart rate. When we say QT more than 450 millisecond is abnormal in men, we mean it is corrected QT interval, and more than 460 millisecond abnormal in women, we again mean that it is a corrected QT interval. Because with heart rate, as the heart rate increases, the total time in diastole also decreases, total time in systole also decreases. So the QT interval will decrease apparently with increasing heart rate. So we have to correct it for the heart rate. But roughly, if we see that the Q to T interval is more than 50% of the distance between two R waves, then it is generally QT prolonged. This is a rough calculation, but actual calculation is by either the Bazet formula or the Framingham formula. Bazet formula is more commonly used, where QT is divided by square root of RR interval in seconds. So we have to first calculate RR interval in seconds, which is generally 1 second or less, and square root of that, QT divided by that square root. So this will give us a corrected QT interval. Again, low voltage complexes in the limb leads is even in chest leads, in limb leads especially, is a feature suggestive of cardiomyopathy, or is a feature suggestive of underlying diseased myocardium. If you see carefully, all the limb leads here are less than total deflection R and S combined is less than 5 millimeter or less than 0.5 millivolts. To conclude, there is no single specific marker of ECG for heart failure. There is a Goldberger triad, but that is not very sensitive or very specific, but we can still use it for suspecting heart failure. ECG acts as a tool for suspicion, not for diagnosis. An ECG should alert the physician for further evaluation by further imaging like echo or MRI or any other modality. Thank you.
Thank you so much, Dr. Ravi. Comments from our chairpersons, Dr. Renuka, Dr. Indira. I must say, as usual, lucid presentation. Once a soldier, always a soldier, as I always say for you, you are up to the mark, to the point.
Thank you, sir.
And it's really amazing that an interventional cardiologist also speaks so well on ECG and non-interventional topic where
Thank you,
a lot of intervention is required. Over to Dr. Indira.
Hi, sir. Hi. As you all know, in our day-to-day practice, other than STEMI, we get maximum patient of heart failure. Dr. Ravi, thank you so much for this wonderful presentation. It was really informative, and thank you so much. Thank you so much.
Thank you. Thank you.
Thank you.
Dr. Renuka. In that case, I would like to thank you so much, Dr. Ravi, for your nice presentation. We will look more from you in coming days. We will be bothering you again and again. Kindly accept the certificate. Also for our chairpersons,
Thank you, sir.
Aditya, Dr. Renuka, Indira ma'am, Dr. Nishant. Thanking Dr. Alka ma'am for being moderator of the session. Thank you so much, ma'am. Dr. Amar, the organizing secretary of the conference. Thank you so much. Last slide of today's session. सभा विसर्जन होत है सुनो वीर हनुमान जे जन जहां से आए हैं तेता करें प्रयाण. Thank you so much, all my speakers, all my chairpersons, all the delegates, ClearNet, Shalini ji, Umaki ji, thank you so much, all of you, for sparing your time. And nice meeting Dr. Deenbandhu Sahu after 6-7 years. Thank you so much. It's nice to see you, all of us together once again. Looking forward to more sessions in coming days. Dr. Deepak, कैसे हैं आप?
बढ़िया बढ़िया
बढ़िया. आपसे अभी पहली बार बात हो रही है.
नहीं, आपके सेशन में थे.
हाँ, आप पूरा शुरू से देखा मैंने आपको. Thank you so much.
अच्छा हुआ. All the topics are very nice and well presented.
Thank you so much, bhai.
Thank you.
Thank you so much. Next time, I guess we should plan something like one topic, maybe just heart failure, and go in full detail only about heart failure.
Yes,
क्या
yes.
Dr. Ravi, ज़्यादा ठीक रहेगा?
That will be better.
After this basic introduction, हम लोग एक एक टॉपिक लेके अगर चले, महीने में एक एक टॉपिक भी, तो I guess we can cover well over a year.
Yeah, true. बिल्कुल सही.
Thank you.
और
Taking
नेक्स्ट
your leave now.
आप उधर आ जाए या हम उधर आ
Thank
जाते
you,
हैं.
sir. Thank you.
Thank you.
ये भी है.
Okay, so thank you so much everyone for extending us the opportunity to host the session, and I hope you had a seamless experience with us. So with all due permissions, I'm closing the session for today and looking forward to hosting you again. Thank you.
Thanks, Himaki. Thank you so much.
Thank you, sir.
Taking your leave now. Thank you.